All right, so let's begin. Sharing, just give me a thumbs up if my voice is clear and screen is visible to you. All right, so let's start. So today we'll be continuing from yesterday's class. And yeah, Sharing, did you receive the recording?
Oh yeah, I did.
Okay, no problem. All right, then let's start from heart failure. So till yesterday we did till cardiomyopathy, and some basics are involved here in heart failure also. So let's just start. Heart failure. So, yes, the clinical syndrome of cardiac pump dysfunction. Okay, cardiac pump dysfunction is what known as heart failure. So, congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue, S3, S4, jugular venous, everything it can be. Okay, see, we are just talking about the general heart failure over here, not about right or left. Okay, I'll tell you when to know whether the question is talking about the right heart failure and when to know whether the question is talking about left heart failure. Okay, so I'll tell you about that. First, let's just do in general and look about all the common features over there. The first one, systolic dysfunction and diastolic dysfunction, and these two are very high yield because they have asked key whether it is systolic heart failure or diastolic heart failure. So you know the basic funda. Systolic heart failure, it means there is a failure in the contraction of the heart. Okay, and diastolic heart failure means the heart is contracting but it is not able to relax properly. Okay, so you can apply the general idea. If it is not able to contract properly, so it will not be able to pump out the blood. Okay, so if it is not able to pump out the blood, then obviously the ejection fraction has to be decreased. Okay, so that's what it is given over here. In systolic dysfunction, reduced ejection fraction. So heart failure with reduced ejection fraction, whereas in diastolic dysfunction, contraction is proper but relaxation is not proper. So some amount of blood will be going on, which will be uh, equalizing to the ejection normal ejection fraction. Okay, so heart failure with preserved ejection fraction. So you have to remember systolic and diastolic, and why this is important, because they have linked this concept to the cardiomyopathy. As we saw yesterday, in the dilated cardiomyopathy, it is because of systolic dysfunction, whereas hypertrophic cardiomyopathy, it is because of diastolic dysfunction. So any of the parameters they can exchange and ask you. All right. So moving again on systolic dysfunction, another term is increase in end diastolic volume. Okay, increase in end diastolic volume, because it will increase the volume of the blood in the heart because it's not able to contract. So obviously the blood will be collected in the heart. So the volume before relaxing, that is what known as end diastolic volume. After relaxing, the end diastolic volume. So there will be more and more volume inside the heart also. Okay, and decrease in contractility. Okay, so these all parameters are very important. Coming to the diastolic dysfunction, the EDV will be normal. Decrease in compliance. Okay, decrease in compliance because the heart is not able to relax. So it will contract, but it will not relax. The heart will become stiff. Okay, so that is what they are talking about in systolic and diastolic dysfunction. Okay, don't forget the parameters and don't forget to link it with the cardiomyopathy, dilated and hypertrophic cardiomyopathy. All right. So now one question they have asked, they will give you the symptoms of right heart failure and then they will ask you which is the most common cause of right heart failure. The answer is left heart failure. Okay, left heart failure. This is very important. In one of the question was there, and even in NBME it was there. Okay, so right heart failure. The most important cause of right heart failure is left heart failure. All right. So these are the drugs: ACE inhibitors, ARBs, neprilysin inhibitors, beta blockers, and aldosterone receptor antagonists. Decrease in mortality in heart failure, reduce ejection fraction. Okay, the most common thing, uh, most important drug that reduces mortality in heart failure. Your answer will be metoprolol. Okay, metoprolol is a beta blocker. So most commonly asked question is this: whether you go for NEET PG exam, they have always asked metoprolol ka importance kya hai. So they preserve, they reduce the mortality in the heart failure patient. So this is very important. Keep this in mind. Another thing, loop and thiazide diuretics are mainly used for symptomatic relief. Now, what symptomatic relief they will be asking you? Like there will be edema. Okay, most commonly there will be pericardial effusion. Okay, so liquid is accumulated in the heart. So what is the role of diuretic? To flush out the liquid from the body. Okay, so this is where they will come over here. All right. So this is all about the general features. Now see one thing, we will discuss about the right heart failure and left heart failure. So what is the problem over here is, see, before going to this flow chart, let me just tell you a general idea. If in the question they are talking about ascites, okay, if they are talking about ascites, if they are talking about JVD, that is jugular venous distension, and peripheral edema, or they are talking about core pulmonal. Okay, if any of these things are present in the question, they are talking about the right heart failure. Okay, see, ascites, it means it can be associated with any congestive hepatomegaly. Okay, so liver के related कोई भी problem हुई, or there is increase in JVD, instead of JVD they will give you JVP also, increase in JVP, jugular venous pressure. Okay, so all these things you need to keep in mind: JVP, ascites, liver failure, peripheral edema, core pulmonal. If all these things are given, the question is asking about the right heart failure. All right. Now, one important parameter to know whether the question is talking about right heart failure or left heart failure, apart from all this, let me tell you, that is central venous pressure. I'll write the full form: central venous pressure, or they will give you JVP, jugular venous pressure. Okay, because it is also a central vein. Okay, so central venous pressure or jugular venous pressure, if they are giving this is very high, think about right heart failure. All right, so this is all about the right heart failure. Coming to the left heart failure will be normal. They will mostly give you like not able to breathe, dyspnea while sleeping, then dyspnea while sleeping, yeah, dyspnea while lying down, pulmonary edema, all those stuff they will be giving you. And here, important point that they will give you is increase in PCWP. Okay, PCWP is a parameter. If they say that the PCWP is increased, it means they are talking about the left heart. Okay, wherever in the question they give you PCWP is high, think about left heart. And if central venous pressure or JVP is high, think about right heart. This is the general rule in cardiology you should be aware about. PCWP जहाँ पे भी दिया है, think about left heart pathology. Okay, and CVP और JVP जहाँ पे भी दिया है, think about right heart pathology. Alright, so बाकी सब तो definition है. इट्स ओके इफ यू डोंट रिमेंबर, जस्ट गो थ्रू देम. बाकी यही आपको जनरल आइडिया है जो मैंने बता दिया आपको. ऑलराइट, यू कैन इग्नोर दिस टू. ये काफी डिफिकल्ट होते हैं तो इग्नोर करो, पूछते नहीं है. या नाउ दिस इज व्हाट इज इंपॉर्टेंट, यू हैव टू अंडरस्टैंड दिस pathway. Actually, it is given more complicated in this edition. 2020 edition में it is given quite simple. Okay, so इसमें देखते हैं क्या complicated है. So decrease in CO, there will be increase in sympathetic tone and increase in RAS. As you know, RAS is a compensatory mechanism of our body. So cardiac output कम हो गया तो RAS activated हो जाएगा. Alright. So increase in sympathetic tone, alpha 1, and this is ADH, angiotensin 2, angiotensin 2, aldosterone, ADH, सब कुछ ऐसा करेगा. So कैटेकोलामाइन अल्फा 1 जो है कॉन्स्ट्रिक्शन करके आर्टियल टोन बढ़ा के मेंटेन कर लेगा. एज अ रिजल्ट स्ट्रोक वॉल्यूम. So basically I am explaining you in my words. See, if the blood coming out from heart is less, okay, what is the compensatory mechanism? First one will be the RAS angiotensin mechanism. Renin will activate angiotensin 2, then aldosterone and everything else. What they will do is they will increase the volume in the heart. Okay, in the body they will increase the volume in the body, and as a result the venous return to the heart will also increase. Preload increase करा देंगे. Okay, so what you need to remember here is कि ये जो angiotensin 2 है और ये जो angiotensin 2 का 1 V1 receptor V2 receptor, at the end what they are going to do is they are going to increase the preload. This is what you need to remember over here. Okay, so V1 or V2 receptors जो है what they will, how they will be helping to improve the cardiac output. What you will remember that they will be increasing the preload. Okay, as we saw in the first class yesterday कि preload कैसे increase होगा. अगर preload को increase करना है तो increase in the body volume. ज्यादा volume डालोगे तो preload increase हो जाएगा. We studied yesterday. Same thing is happening over here. V1 and V2 receptors उनका role होगा कि body का volume बढ़ाए. They will increase the fluid inside the body. So as the fluid is increasing, preload is going to increase. Okay, so one concept done. Second, increasing sympathetic tone. It means either beta 1 receptors or alpha 1 receptors will be activated. Now, what will happen if we go towards the alpha 1? It the arteries will be constricted. If arteries will be constricted, the resistance will increase. If resistance will increase, there will be increase in blood flow. Okay, if increase in blood flow, volume will increase, and as a result, stroke volume is going to increase. Is that clear? तो अल्फा 1 का मैकेनिज्म ये है. कमिंग टू बीटा 1, इट विल इंक्रीज कॉन्ट्रेक्टिलिटी एज वेल एज हार्ट रेट. हार्ट रेट इंक्रीज कर दिया तो कार्डियक आउटपुट मेंटेन हो जाएगा, एंड कॉन्ट्रेक्टिलिटी कर दिया तो स्ट्रोक वॉल्यूम मेंटेन हो जाएगा. ऑलराइट, सो आई होप दिस इज क्लियर. This pathway is very clear and very important. They will ask you one word based on this. So this alpha 1, beta 1, V1, V2, ये सबके functions you should be knowing. All right. 2020 edition में it was completely different flowchart. Uh, Wait a minute, I will click a photo and I'll share with you. Yeah. So see, this is what the image was given in the 2020 edition. All right. So you can see ये यहाँ पे दिया हुआ है. All right. This is what is given over here. So let's just see what is given here. LV contractility decreases, so pulmonary venous congestion and cardiac output decrease. Okay. Left ventricle is not able to contract, so cardiac output will decrease. Let's just go towards the cardiac output first. LV contractility decrease, तो cardiac output कम हो जाएगा. So as we saw, RAS angiotensin mechanism increase हो जाएगी, sympathetic activity increase हो जाएगी. We saw. All right. So what they will do is increase in reabsorption, increase in contractility, and increase in preload and cardiac output. So what they did in the new edition is they expanded this concept. Okay, they expanded this concept. So this is what they have done in 2022-2023 edition. Okay, so जो हमने discuss किया उनको ज़्यादा explain किया. Now coming to pulmonary venous congestion, this is new. This is not given in that book. So उसमें देखते हैं pulmonary venous congestion. तो gas exchange कम हो जाएगा. There will be pulmonary edema. There will be decrease in right ventricle output. I hope you are able to carry out think about this. Pulmonary vein की congestion हो गई, so blood won't be going ahead into the left side of the heart. Okay, so वहाँ पे vein blood accumulate हो गया, it will be flowing back to the right ventricle. So right ventricle का output कम हो जाएगा क्योंकि right ventricle में blood इकट्ठा होते जाएगा, वो बाहर भेज ही नहीं पा रहा है. Okay, there will be pulmonary edema because so much of blood is accumulated in the pulmonary vein, so it will be leaking out. Okay, and impaired gas exchange क्योंकि lungs में blood बढ़ जाएगा, so much fluid in the lung, so alveoli won't be able to function normally. Okay, so this is what is happening. ये कम हो जाएगा तो आरवीपी, राइट वेंट, मैंने क्या बोला, राइट हार्ट का फेल होगा तो सिस्टमिक वेनस प्रेशर और सेंट्रल वेनस प्रेशर और जुगुलर वेनस प्रेशर विल इंक्रीज. ऑलराइट, एंड एज अ रिजल्ट देयर विल बी पेरिफेरल एडिमा. सो आई होप दिस कॉन्सेप्ट इज क्लियर. इसमें ये पार्ट नया दिया हुआ है. दिस ऑल वाज एक्सप्लेन ब्यूटीफुली इन दिस न्यू फ्लो चार्ट. ऑलराइट, दैट इज व्हाट आई वाज टेलिंग यू. आई विल शेयर दिस इमेज इन द ग्रुप, डोंट वरी. So this is all about the heart failure that you have to remember. So many concepts here, but yeah, at the same time they will be asking you so many questions. Remember this fighting edema image. Yeah, don't worry about the management and treatment. They are not going to focus more on that in step one. In step two, they will be focusing more. Okay. So for now, अपने को बस ये basic आना चाहिए. How to differentiate between right heart failure, left heart failure, what are the complications in both of them, and what are the parameters: ejection fraction, left ventricular and diastolic volume, contractility, and what type of cardiomyopathy will be associated with systolic and diastolic dysfunction. So these all things you should be knowing. Rest all just ignore. Okay, so that's it for the heart failure. Let's move ahead. We have high output heart failure. So high output heart failure, actually this is not in the old version, but in the UL so many questions are there regarding high output heart failure. Let's just see what you will be doing here. Uncommon form of heart failure characterized by increasing cardiac output. Okay, yeah, heart failure is increased by cardiac output. Okay, high output state is due to decrease in SVR from either vasodilation or arteriovenous shunting. Causes include obesity, cirrhosis, severe anemia. So all these extra diseases will be causing high output heart failure. Okay. Why it is occurring? Because all the other diseases are increasing the load on the heart. So load on the heart is increased, cardiac output to increase हो रही है, but load increase हो रहा है, so heart थक जाएगा. Simple thing. All right. So let's just do the shock. Guys, shock very, 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 very high yield. Definitely 2-3 questions will be asked from here. And how they will be asking you? Parameters. These parameters are very important. If you are not able to understand it, try to remember, take the printout and stick it in front of you. All right. First wala, hypovolemic shock. So you have to remember the case. Either it will be hemorrhage, dehydration, or burn. You have to remember this. Okay. On the basis of this only, you will be able to identify what type of shock they are talking about. Okay. If the patient of dehydration or if it is a trauma and loss of blood is occurring, that is hemorrhage, and third is burn. Okay. So this you can avoid. So अभी देखते हैं CVP एंड ये सब में क्या होगा. तो यू हैव टू रिमेंबर द एरोज. CVP मींस राइट हार्ट का होगा, तो ये डिक्रीज हो जाएगा. PCWP डिक्रीज हो जाएगा. CO डिक्रीज, SVR इंक्रीज, SpO2 डिक्रीज. SpO2 is normally they don't ask, but in UL so many questions are there. So just for the sake of UL, just read this. But ये सब तो आपको याद रखना ही है. Okay, these 4 parameters are very very important. Please remember this properly. Okay, so see, ब्लड से सॉरी बॉडी से ब्लड लॉस हो रहा है, सो एवरीथिंग इज डिक्रीजिंग एक्सेप्ट रेजिस्टेंस. डेफिनेट है, इफ ब्लड इज गोइंग आउट ऑफ द बॉडी, द आर्टरीज विल स्टार्ट कॉन्ट्रैक्टिंग, constricting, and if it will constrict, resistance will be increasing. Simple funda. Okay, coming to cardiogenic shock. Now in cardiogenic shock you have to remember this: MI, heart failure or arrhythmia? Am I heart failure, arrhythmia? Okay. So यहाँ पे left heart dysfunction है. Now I told you if it is left heart dysfunction, PCWP is supposed to be increasing. PCWP increase हो रहा है तो उसके पहले वाली भी चीज इंक्रीज होनी चाहिए ना. So it can be because of CVP will also be increased. CVP increase जाएगा तभी तो PCWP increase होगा. Okay. Don't use it generally. Use this only in the case of shock. Because in case of shock, the body is crying, begging for oxygen and begging for the blood. Okay. So that's why CVP भी यहाँ पे increase होगा. कार्डियक आउटपुट डिक्रीज हो जाएगा. SVR इंक्रीज. ओके. ऑब्स्ट्रक्टिव शॉक में मोस्ट कॉमन दे आस्क अबाउट पल्मोनरी एम्बोलिज्म एंड कार्डियक टेम्पोनाट. ओके. ऑब्स्ट्रक्टिव शॉक यहाँ पे राइट हार्ट डिसफंक्शन है तो सीवीपी तो इंक्रीज होगा, पीसीडब्ल्यूपी भी इंक्रीज होगा एंड दिस ऑल गोइंग टू बी सेम. ऑलराइट. ये तीनों में आप देखोगे तीनों में ये सेम हो रहा है. Alright, coming to the distributive shock. Now, distributive shock mein there will be two things. One will be CNS injury and one will be sepsis. Sepsis means some bacterial infection is going on and after some time the effect is seen in the brain. Okay, that is what known as septic. That is what a type of septic shock that you have said. So it is a type of distributive shock. तो इसमें आपको देखना है सीवीपी दोनों में डिक्रीज होगा, पीसीडब्ल्यूपी दोनों में डिक्रीज होगा. ओके. नाउ यू हैव टू सी एसवीआर भी दोनों में डिक्रीज हो रहा है. जस्ट कार्डियक आउटपुट का आपको फंडा देखना है. Okay, so based on cardiac output, based on the cause, you will be asked to do the parameters. Okay, and mark my words, this is very 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 important. Shock is very important. इसमें कोई concept नहीं पूछेंगे. They will just ask you the parameters and how you will be distinguishing the parameters based on the causes. Okay, so any of the case will be given to you. You should be identifying yourself कि कौन सा type का shock होगा ये, and based on that you have to mark the parameters. Okay, very high yield. So many questions have been asked in NBME as well as UL, and in exam also I got 3 to 4 questions from this. Okay, so shock by heart Radkeda. Now coming to cardiac tamponade. Now in cardiac tamponade, one thing they will give you very common. Okay, and that is back triad. Back triad में क्या होता है? Hypotension, distended neck vein and distant heart sound. So most common out of this will be distended neck vein. They will give you distended neck vein. Okay, ये देंगे ही देंगे. Another thing, pulsus paradoxus. Another thing, ECG will show low voltage QRS and electrical alternance due to swinging movement of heart in large effusion. Now see, cardiac tamponade is the only condition where you will find electrical alternance plus pulsus paradoxus. Okay, so actually ये तो मेडिसिन नीट पीजी का सवाल है, but if in question you get it, don't confuse. Electrical alternance भी है and pulsus paradoxus भी है, so don't worry about it. All right, and this is the ECG you have to remember for cardiac tamponade. Same ECG will be given in the question. Okay, now let's just see what happens over here. Is echocardiogram shows pericardial effusion, systolic RA collapse, diastolic RV collapse. This is not necessary. Okay, so you can avoid this. Okay, coming to pulsus paradoxus, decrease in amplitude of systolic BP by 10 mg during inspiration. This is very important. Okay, in the question they might give you this line or they will give you distended neck veins or any one component of the back triad. Okay, so what will happen because of this? Venous return will increase during respiration, RV filling, interventricular septum. ये सब आपको देखना पड़ेगा. बाकी it's not important from the exam point of view. Just read it so that you understand. And another thing is, it is seen in constrictive pericarditis, obstructive pulmonary heart disease, and cardiac tamponade. One important point they have not given over here is, write it down. Uh, yeah, prominent X descent and blunted Y descent. Okay, this is very important because यहाँ पे दिया हुआ नहीं है. But when we saw that Vickers diagram, okay, in physiology में जो diagram देखा था, I shown you A C X Y wave. Okay, तो उसमें X descent and Y descent का यही मतलब है. Cardiac tamponade में you will see decrease in Y descent but increase in X descent. Okay, this is very important. So many questions have been asked over here. And another thing that you need to remember here is, yeah, water bottle sign is important. Water bottle sign. Okay, so I'll repeat what all is important for cardiac tamponade. First of all, back triad is important, and most common component of back triad is distended neck vein. Second is cardiac tamponade is condition with electrical alternance plus pulsus paradoxus. What is pulsus paradoxus? Decrease in amplitude of systolic BP greater than 10 mmHg during inspiration. Okay, Another thing, it can pulsus paradoxus can be seen in constrictive pericarditis, obstructive pulmonary disease, and cardiac tamponade. Okay. Another thing, prominent as they said, decrease in Y-diction. Remember this ECG, and that's it. All right. That's it for the cardiac tamponade. Moving ahead, we have infective endocarditis. So in infective endocarditis, what they will ask you, they will mostly ask you about the organism that is causing infective endocarditis. All right. So let's just see what are organisms you to remember. Some extra organisms I will add it for you, so you can note that down. Infection of endocardial surface of heart, typically involving greater than one heart valve. Okay. So it is caused by bacteria. Bacteria is most common. So let's just see what bacteria are given over here. Acute and subacute. Acute means Staph aureus. Staph aureus will be occurring on previously normal valve, okay, and subacute may widen streptococci, and it will be on the disease valve, okay. You should know the difference. कि अगर पहले normal थे, it is Staph aureus, but if it is diseased already, it will be widened streptococci. And the important thing, in the question, in the exam, they will give you sequel of dental procedures. The patient will come to you, and 2 weeks back or 3 weeks back, they will say there was some dental surgery going on this patient. As a result, the dentist didn't take proper care, didn't give the post prophylactic antibiotic. Okay, so as a result, infection occurred, and that infection passed on to the heart, and that is result of infective endocarditis through dentistry. Okay, so this is also important. Sequel of dental procedures, and if dental procedures is there, your answer will be wide and streptococci. Okay, this is very important. So note this down. Another important point, I am writing few more bacteria. You should note it. Strep bovis. Strep bovis will be associated with colon cancer. Okay, अगर colon cancer दिया है and there is endocarditis patient, think about the strep bovis organism. Okay, in usual questions are there. Enterococcus. Enterococcus में surgery in GI or GU tract. GI means gastrointestinal, GU means genitourinary tract. Okay, what else is, that's it. Okay, so these two bacteria are also very important. Apart from them, Staph aureus in completely normal valves, Weiden streptococci in damaged valves, and dentistry, post dentistry. Okay, so let's just see how symptoms present with fever, murmur, vascular, pneumologic phenomena. Okay, so ये symptoms है. Let's just see vascular phenomena क्या होता है. Septic embolism, petechia, splinter hemorrhage. See, splinter hemorrhage is very important. They will show you this image in the exam. Okay, splinter hemorrhage दिखाएंगे अगर nail में, if you are seeing hemorrhage like this and this white layer, think about splinter hemorrhage. The question is talking to you about infective endocarditis. All right. Janeway lesions, painless flat erythematous lesions on palms or soles. Janeway lesions. All right. Immunologic phenomena में क्या आएगा? Immune complex deposition. So ocular nodes. Okay. So these are what ocular nodes is. Raised bilateral lesions on finger or toe pad. Rot spot, retinal spots. Okay, these are what rot spot is. Now see, one important question they asked to me in the exam was, it was quite surprising. Okay, they asked to me what is the immunologic phenomenon cause and what is the vascular phenomenon cause. Okay, so they gave me 2 3 options, and I have to select whether it is going on the basis of immunology phenomena or vascular phenomena. Okay, very smart. This you can already easily ignore, easily avoid it. But I got the question, and you are lucky that I am sharing with you. All right, vascular phenomenon and immunologic phenomenon. You have to remember कौन से vascular में आ रहा है, कौन से immunologic में आ रहा है. All right, so all these are very important. Another thing, over here is, if we go from the medicine perspective. Okay, medicine perspective, and as you know, step one is based on medicine only. So what they have said कि major criteria for diagnosis is the symptoms, damaged valves, and culture, bacterial culture. And all this that we are seeing, Janeway lesion, Roche spot, ocular node, these all fall under the minor categories. Okay, these all fall under the minor criteria. Okay, ये जो अपन ने vascular phenomenon और immunologic phenomenon देखा, these are minor criteria. Whereas major criteria is valve, culture, and damage symptoms, fever, वो सब. Okay, so make sure they might ask you. Now coming to mitral valve is the most common, then aortic valve. Okay. Now another criteria, another case. Tricuspid valve involvement is associated with drug use. Now see, a general rule of cardiology, if they want to ask you valve disorder, okay, valve disorder, and they say the patient is IV drug user, आंख बंद करके go for tricuspid valve. Either it can be tricuspid regurgitation, it can be tricuspid stenosis, it can be tricuspid atresia, anything. If in the question they are saying the patient was an IV drug user, think about tricuspid. कुछ भी हो, tricuspid होना जरूरी है. All right. So this is very important. Generally, cardiology point of view से भी. So common associations, another associations are given here. Prostatic valve में epidermitis, GI I noted down, colon cancer I noted down, gram negative HX organism. So it's okay, they have never asked. So you can actually avoid this. कोई problem नहीं है. Yeah. If in the question they say that the culture tested negative, you should not think that it is not an infective endocarditis. It is infective endocarditis, but it may be caused by Coxiella or Bartonella. Okay. So Coxiella किससे होते हैं? Sheep से, and Bartonella is by cat. Okay, we'll discuss this in micro. So injection drug use में Staph aureus, Pseudomonas candida. Okay, but it will be affecting tricuspid valve. Keep this in mind. तो यहाँ पे होता कैसे है देख लेते हैं. Endothelial injury, formation of vegetation consisting of platelets, fibrin and microbes on heart valve, valve regurgitation, septic embolism, systemic circulation in left side endocarditis, pulmonary in right side. Now see one thing, they will ask you the vegetation on the heart. Vegetations on heart consist what? Answer will be fibrin plus platelets plus microbes. Okay, this question has been asked, so you should remember this. All right, so this is all about the infective endocarditis. Each and everything is important to how the questions will be presented to you. So make sure you do them properly. All right, coming to non-bacterial thrombotic endocarditis. Now non-bacterial. Now what they will say over here is uh, they will say that the blood culture is negative. There will be no fever. Okay, let's just see इसमें क्या क्या है. Typically arise on mitral aortic valve and consists of sterile platelet rich thrombi. This is very important. One question is there in UL regarding this. Platelet rich thrombi आता है, so it will be non-bacterial thrombotic endocarditis. Whereas if it is infective, it will be fibrin plus platelets plus micro. All right, so this is very important. You need to remember. That's it. Done with infective endocarditis. Moving on to the rheumatic fever. Rheumatic fever. Okay, first of all, this image is very important for rheumatic fever, so make sure you know this. Now, what is there in this image? Let's just discuss. A consequence of pharyngeal infection with group A beta hemolytic streptococci. You have to remember the organism name. Group A beta hemolytic streptococci. Don't confuse this with infective endocarditis. Okay, infective endocarditis में A beta streptococci नहीं है, वहाँ पे specifically name दिए हुए. All right. So if A beta hemolytic streptococci आपको बोल रहे हैं, think about rheumatic fever. Okay. So late sequelae include rheumatic heart disease. It will affect mitral and then it will affect aorta and tricuspid. Now this another line very important over here. Early valvular regurgitation, late valvular stenosis. It means कि सबसे पहले it will be mitral regurgitation, then mitral stenosis. But here what you need to remember here is if they are asking about mitral, okay. So mitral valve first, mitral stenosis, then aortic regurgitation, then aortic stenosis. All right. So this is the order that you have to follow. Okay. So associated with ESCOP bodies, what are ESCOP bodies? Granuloma with giant cells, Aniscope body that is enlarged macrophages with ovoid vivid rod-like nucleus. Okay. So now see, this you have to identify ESCOP and Aniscope. Okay. But the problem is, you know what the problem is? Instead of name, they will give you this description. Okay. Bracket का description दे देंगे and you will have to identify कि बात क्या कर रहा है question. Okay. So bracket का you have to remember. Moving ahead. Anti-streptolizin O and anti-DNase B titers. This is the diagnosis for group A beta hemolytic streptococci. Okay. Now, if it is immune mediated, तो एंटीबॉडीज टू एम प्रोटीन क्रॉस रिएक्ट विद सेल्फ एंटीजन ऑफन मायोसिन, ये याद कर लेना. एक्चुअली वन क्वेश्चन वाज देयर इन एनबीएमई रिगार्डिंग दिस. ओके, so बस go through कर लेना. And these are the criteria, Jones criteria you have to remember. Joint, heart, nodules, that is subcutaneous erythema marginatum, Sydenham chorea. Okay, Sydenham chorea will occur in the basal ganglia. Okay, they have asked this, where does the Sydenham chorea occur? So we saw chorea कहाँ पे होती है? In the CNS. We saw it occurs in the basal ganglia part. Okay, so that's it for rheumatic fever, I guess. So let's just see, ये पूछा तो नहीं है syphilitic heart disease, but discuss कर लेते हैं. Third, diabetes disturb the vasa vasorum of aorta with consequent atrophy of vessel wall and dilation of aorta and valve ring. So dilation of aorta, it means syphilis. हमने कहाँ पढ़ा था? Can anyone recall? Sharon, can you recall? Yesterday we did one condition where syphilis was involved. Can you recall? नहीं आ रहा? Aneurysm. We did this in the aneurysm. Okay. I think abdominal aneurysm. Okay. So remember this. Aneurysm may be syphilis can also cause aneurysm. Okay. Basic calcification of aortic root, ascending aortic arch and thoracic aorta, tree bark appearance of aorta. This is very important. Microbiology point of view, say tree bark appearance of aorta, very important. Okay, so that's it. We are done with the rheumatic fever, syphilitic heart disease. Now next we'll be doing pericarditis. Okay. Now one thing, inflammation of pericardium तो पता है. Now this is very important. Commonly presents with sharp pain, aggravated by inspiration and relieved by sitting up and leaning forward. This line is very important. If they say इंस्पिरेशन करते वक्त पेन हो रहा है, शार्प पेन हो रहा है, एंड व्हेन द पेशेंट इज सिटिंग अप पेन इज रिलीव. इफ पेशेंट इज लाइंग देयर इज पेन, एंड इफ पेशेंट इज सिटिंग अप पेन इज रिलीव. ओके, सो यू शुड रिमेंबर दिस. तो मैं लिख देता हूँ, वर्स while lying flat. Okay, words while lying flat, very important. All right, तो देखते हैं और क्या है. Pericardial effusion, widespread diffuse ST segment elevation and PR depression. Friction rub is important. Surgery, connective tissue disorders, cardiovascular events, all this, radiation, renal failure, idiopathic infection. Now see, most common cause is viral infection. It can be either pericarditis, it can be either myocarditis. Most common cause is viral infection. Okay, viral infection very important. Okay, that's it. और कुछ नहीं है. Pericarditis में they will ask you the friction rub, then they will ask you this symptom. Worsen while lying flat and pain relieved on coming up. बस ये दो पॉइंट आपको याद रखने हैं. यू आर गुड टू गो फॉर पेरिकार्डाइटिस. ऑलराइट, कमिंग टू मायोकार्डाइटिस, इन्फ्लेमेशन ऑफ मायोकार्डियम, global enlargement of heart and dilation of all the chambers. Major cause of HCD in adults less than 40 years of age. HCD is sudden cardiac death. Okay, presentation can include dyspnea, chest pain, fever, arrhythmia. सारी फीचर्स पकड़ लो, ठीक है, सारी फीचर्स पकड़ लो. बट मोस्ट ऑफ द कॉज दे विल आस्क यू इज viral is the most important, and उसमें adenovirus, coxsackie B virus, parvovirus. Coxsackie B, we will do this in micro. Okay, so if they ask you the most common cause of myocarditis, most common cause of acute pericarditis, think about viral infection. Okay, तो ये याद रखनी है आपको, बाकी कुछ याद नहीं करना है इसमें. Okay, so we are done with myocarditis. Yeah, one more thing. If the question asks you about constrictive pericarditis, what important you have to remember here is rapid Y descent. Okay, यहाँ पे you have to remember rapid Y descent, whereas it is opposite in cardiac tamponade. Okay, cardiac tamponade में blunted Y descent, but यहाँ rapid Y descent. So this is the differential diagnosis. ओके, तो टम्पोनाड में रैपिड एक्ट डिस्टेंट होती है। राइट दिस डाउन, दिस इज वेरी इंपॉर्टेंट क्वेश्चन आए हैं यूएल एनबीएमई जनरल। ऑलराइट, लेट्स जस्ट सी व्हाट इज गिवन अहेड। We have tumors. So in tumors, you have to remember myxomas. Okay, myxomas याद करना है. You will have so many questions. Most common cardiac tumor in metastasis. The most common primary cardiac tumor in adults. 90% in atria. Myxoma usually described as a ball valve obstruction in the left atrium. Left atrium is important. So IL-6 production by tumor. Constitutional symptoms तो आएंगे fever, weight loss, etc. So there will be tumor plop sound and yeah, murmur and symptoms worsen in upright position, improve when lying down. Opposite to acute pericarditis. Okay, acute pericarditis means when you are lying down, they are worsening. When you sit upright, they are improving. Okay, यहाँ पे उल्टा है. So write down opposite to acute pericarditis. Another thing that you have to remember here is histology, that is gelatinous material myxoma cells immersed in glycosaminoglycan. This is very important. So what all things in myxoma is? It occurs in atria, ball valve that is obstructing the left atrium, tumor plop sound. Then when you are lying down, it improves. When you are sitting upright, the pain occurs. And histology, gelatinous material, myxoma cells immersed in glycosaminoglycan. Alright, that's it. That's it. And what else is? Yeah, hereditary hemorrhagic telangiectasia. Now, how the case will be presented to you over here is uh, the NBME will show you the image of a lip plus dark spot. Okay, एक lips का image रहेगा and on the lip they will show you various dark spots. Okay, plus they will say what they will say. Wait, I have written the case. Yeah, they will say dyspnea plus increase in ejection fraction. Your answer will be hereditary hemorrhagic telangiectasia, and the most common answer they want is atriovenous malformation. Okay, write down this case. काफी ये ध्यान में नहीं आता है. This is very underrated question, but it has appeared in the exam. Okay, so I want you to remember this. So that's all. We are done with the pathology. पहले pharma कर लेते हैं, then I continue with vasculitis. Okay. All right. Primary hypertension, thiazide, ACE inhibitors, ARBs, everything we can give for primary hypertension. Coming to hypertension with heart failure, beta blockers avoid करने का, and that's it. Okay, if you are giving ARB, you should combine it with sacubitril. Okay, coming to hypertension with diabetes mellitus, ACE inhibitors or ARBs are given. Okay, ACE inhibitors or ARBs are given. बीटा ब्लॉकर्स नहीं देने का, क्योंकि उससे हाइपोग्लाइसीमिया हो सकता है. Coming to hypertension in asthma, so here you won't give ACE inhibitors. Okay, hypertension in pregnancy, these are the drugs: nifedipine, methyl-dopal, labetal, hydralazine. Now see, if they give you a case of hypertension, now they won't ask you what is the drug of choice for hypertension or what is something like that. They will give you this case: the patient with hypertension and asthma, patient with hypertension and diabetes. Okay, patient who is pregnant comes with hypertension. Like this they will give you, and I already marked it down for you. So remember the cases: ACE inhibitors asthma में नहीं देते, diabetics में ACE inhibitors and ARBs you give both of them, and pregnancy में remember this 4 drugs. All right, moving ahead. So this is the general mechanism of action of all the drugs that we are going to discuss. So give it a look. Okay, especially ये part पे ज़्यादा ध्यान देना, अच्छे से देखना. Just look at this image and try to build this image in your mind, because step 1 is going to focus on the pathophysiology and basics mechanism only. So they might ask you any of the words from this. Okay, so you should be thorough at least mechanism एक बार देख लेना. Okay, now let's discuss the mechanism one by one. First, calcium channel blockers. तो calcium channel blockers, remember the drugs dihydropyridine and non dihydropyridine. ये नाम याद रख लो कौन सा dihydropyridine है कौन सा नहीं है. Mechanism, blocked voltage gated L type calcium channels of cardiac and smooth muscles to decrease in muscle contractility. So we'll see vascular smooth muscle में कौन से आएंगे and heart पे कौन से आएंगे. So there are two types of calcium channel blockers, one that acts on vessels and one that will directly act on heart. Okay, हार्ट पे ऐड करने वाले वेरापिमिल डिल्टियाजम. ओके, सो मेक श्योर यू नो देम. कमिंग टू क्लिनिकल यूज, डायहाइड्रोपेरिडीन जो होते हैं एक्सेप्ट निमोडिपिन, हाइपरटेंशन, एंजाइना, रेनल फिनोमेनन सब में. या ये रेनल फिनोमेनन इज वेरी इंपॉर्टेंट. आई होप यू नो रेनल फिनोमेनन, चेंज इन द कलर ऑफ फिंगर्स. ओके, एंड एक्सपोजर टू कोल्ड. तो रेनल फिनोमेनन को ट्रीट करने के लिए वी गिव कैल्शियम चैनल ब्लॉकर. ऑलराइट, निमोडिपिन जो है सब एरेक्नॉइड हेमोरेज में यूज होता है. इट प्रिवेंट्स सेरेब्रल वैसोस्पाज्म. वी डिड इट इन सब एरेक्नॉइड हेमोरेज. निकाडिपिन, क्लेविडिपिन, हाइपरटेंसिव इमरजेंसी. नॉन डायहाइड्रोपाइरिडिन, हाइपरटेंशन, एंजाइना, ये सब. Okay, so they won't actually ask this, but one question they have asked over here is hypertensive emergency or urgency, what drug you will give. So answer will be nicardipine or clevidipine, calcium channel blockers. Okay, so ये सब चीजें आपको याद रखनी है. And one thing they love to ask about most frequently is ये dihydropyridine जो है ना, peripheral edema. The most common they will give you about amlodipine. Okay, the question they will say you, the patient was on amlodipine and what will be the most common side effect over here. So answer will be peripheral edema. Okay, along with that gingival hyperplasia भी आपको याद रखनी है. And non dihydropyridine का AV block, hyperprolactinemia, verapamil जो होती है, and constipation. Okay, so if they are talking about the peripheral edema, think about dihydropyridine, most common being the amlodipine. Okay, that's all about the calcium channel blockers. Remember कि vascular में कौन से है, heart पे कौन से है. Okay, these two features, these 2 points will help you to solve many questions. Moving to hydralazine. Hydralazine क्या करता है, smooth muscle relaxation and it vasodilates arterioles. Arterioles पे focus करना. Okay, arterioles पे focus करना. Clinical use you can avoid. Adverse effect is compensatory tachycardia, fluid retention, headache, angina, and this is important. Adverse effect and mechanism is important over here. Clinical use, it's okay. You won't be asked. Okay. Arterioles पे focus करना. Arterioles is important. Hypertensive emergency. So calcium channel blockers तो होते ही है. Along with that, there are many other drugs. Nitroprusside, short acting vasodilators, both arteries veins दोनों पे equally करते हैं. Increase in CGMP via direct release of NO. See here also in hydralazine, increase in CGMP. In hypertensive emergency, nitroprusside is also increase in CGMP. So increase in CGMP is very important. And sometimes CGMP की जगह they will give you increase in guanylyl cyclase. Guanylyl cyclase. Okay, so confused नहीं होना है. CGMP, guanylyl cyclase, everything is same thing. All right. Phenol D1 receptor agonist. So यहाँ पे coronary and planktonic vasodilation. Now one thing over here is they will say what they will say. Yeah, they will I give you any artery plus they will say there is a constriction. Which drug you will give? So you will be giving phenol because it is planktonic vasodilator. Okay, planktonic vasodilator है. So यहाँ पे you will be giving phenol. All right. Coming to nitrate. Remember the drugs. Another thing, vasodilate by increasing NO in vascular smooth muscle, increasing CGMP in smooth muscle relaxation, dilate veins greater than arteries. Dilate veins greater than arteries. If they are going to dilate, preload कम हो जाएगा. We did this in the first class. Okay. So यहाँ पे angina and everything you can remember. Coming to adverse effect. Adverse effect is very important. Why? Because reflex tachycardia, methyl hemoglobinemia, hypotension, flushing, headache. So this Monday disease is very important. In industrial nitrate exposure, development of tolerance for vasodilating action during the work week and loss of tolerance over the weekend. So tachycardia, dizziness, headache upon re-exposure. This is very important. They have asked in UL. 2 to 3 questions are there in UL regarding this. Okay. Contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. Concurrent PDE5 inhibitor use के साथ It means PD5 inhibitor कौन से है? Sildenafil. Okay. So if in the case they will give you the patient is having erectile dysfunction and you gave sildenafil, which other drug you should avoid? So you should avoid nitrate. ओके दिस इज वेरी इंपॉर्टेंट. ये काफी कॉमन है एंड दिस इज फॉर श्योर गोइंग टू कम इन एग्जाम. 100% एग्जाम में आएगा. 2-3 NBM is this question. You world is having so many questions and definitely this is going to come in exam. Remember nitrate should never be given with PD5 inhibitors because they will cause vasodilation. There will be hypotension. The patient will go into hypotension state. BP एकदम कम हो जाएगा. All right. That's what about nitrates. Coming to anti-anginal therapy, ये आप छोड़ दो. All right, just leave this. No need to worry about it because one or two questions are there in UL regarding this and they have confused it. So ये आप पार्ट छोड़ दोगे तो बहुत अच्छा होगा. अगर आपको नहीं छोड़ना है so I'm writing few points, just write them down. Labetalol increase in LVEP, decrease in CO, decrease in PVR. Okay, labetalol का ये function है. So yeah, one point. Beta blockers. This is important because UL का line है ये. बाकी if you want you can avoid it easily. Okay, so yeah, beta blocker slowing rate of diastolic depolarization. This is important. Slowing the rate of diastolic depolarization beta blocker का ये function है. So in the UL this is the line that they have given. So make sure you know that. Okay. बाकी इसमें कुछ important है नहीं. So you can avoid this. This is just about high yield stuff. ये आपको step 2 CK में बहुत आएगा. But in step 1 they haven't focused much more. Okay. So 2-3 points you can remember. Coming to ranolazine. Ranolazine inhibit the late phase of inward sodium current, thereby reducing diastolic wall tension and oxygen consumption. Do not affect heart rate or blood pressure. That's it. Mechanism याद रखना. Sacubitril, a neprilysin inhibitor, prevent degradation of bradykinin, natriuretic peptide, angiotensin 2 and substance P. So vasodilation increase करेगा, ECF volume कम करेगा. Just remember neprilysin inhibitor and it causes increase in vasodilation. Okay. Used in combination with valsartan to treat heart failure with reduced ejection fraction. मतलब systolic dysfunction में you can give this. Okay. Side effects are important because UL में पूछा है sacubitril का side effect. Okay, so hypotension and hyperkalemia is very important. Contraindicated with ACE inhibitors due to angioedema. Both drugs will be increasing bradykinin. Okay, so angioedema is important, hyperkalemia is important, neprilysin inhibitor is important. All right. So these are the general anginal drug, heart failure drugs. So now we'll be moving on to lipid lowering agents, antiarrhythmic drugs, and digoxin. Okay. Now one thing before starting lipid lowering agents is see, in lipid lowering agent, you have to remember a drug name, you have to remember the LDL, HDL and triglyceride level, and you have to remember the mechanism. Mechanism becoming very high yield. Okay, mechanism के साथ बहुत confuse करेंगे ये लोग. Okay, side effects तो करने ही है. So this is the very high yield, and I found it little difficult because so many mechanisms and so many things to remember over here. Okay, so देखते हैं. First one, statin. ओके स्टैटिन है एलडीएल कम करेगा एचडीएल बढ़ाएगा ट्राइग्लिसराइड कम करेगा इनहिबिट कन्वर्जन ऑफ एचएमजीएच यूए टू मेवालानेट अ कोलेस्ट्रॉल प्रिकर्सर डिक्रीज इन इंट्राहेपेटिक कोलेस्ट्रॉल increase in LDL receptor cycling increase in LDL catabolism all these three lines are very important because sometimes they will say we know कि LDL decrease कर रहा है okay we know LDL is decreasing but how what they will say LDL receptor recycling will increase or decrease so recycling increase होगी तभी तो LDL decrease होगी ना body में से okay so make sure this is how they are going to test you another thing hepatotoxic होते हैं especially when used with fibrates or niacin. One thing I wanted to write here. Yeah, this one only. कि फाइब्रेट जो है, वाई बिकॉज इट इनहिबिट्स P450 एंजाइम। ओके ये है। एंड रिमेंबर वन थिंग, आई एम रिपीटिंग अगेन अबाउट statins. Decrease in LDL in highest concentration. Okay, if they say which drug, which lipid lowering agent decreases the LDL to a high extent, answer will be statin. Another one, mechanism याद रखो. And yes, so decrease in intrahepatic cholesterol, but it increase in LDL receptor recycling. Receptor recycling increase होगा, but LDL decrease होगा. Okay, it is hepatotoxic. And remember not to give them with fibrates and niacin. Okay, ये याद रखना. Coming to bile acid resins, remember the names, remember this. And yeah, one important question they love to ask in bile acid resins is which lipid lowering agent, LLA is lipid lowering agent, increases triglyceride. भले slightly है, no matter it is slightly, but question will be asked which lipid lowering agent increases triglyceride. Your answer will be bile acid resin. Okay, prevent intestinal reabsorption of bile acid. Liver must use cholesterol to make more. तो यहाँ पे ड्रग एंड फैट soluble vitamin decrease absorption. Okay, एजिटेमाइड डिक्रीज इन एलडीएल, एचडीएल इंक्रीज होगा थोड़ा, ये सब तो नॉर्मली है. ओके, इट इज नॉर्मल. प्रिवेंट कोलेस्ट्रॉल एब्जॉर्प्शन एट स्मॉल इंटेस्टाइन, ब्रश बॉर्डर. ओके, स्मॉल इंटेस्टाइन पे एब्जॉर्प्शन कम करेगा, वेयर एज बाइल एसिड रेजिन इंटेस्टाइनल रीअब्जॉर्प्शन ऑफ बाइल एसिड. one word का difference you have to pick out because questions will be asked similarly, line दी जाएगी and you have to identify the drug. Okay, so ezetimibe also liver and diarrhea. Moving ahead, we have fibrates, LDL come, HDL come. And yes, question, which lipid lowering agent decreases triglyceride most extensively? Answer will be fibrate. एक्टिवेट पीपीआर, एग्लूटिनेट टीजी, ये सब आपको याद करना है, ये पूरी मैकेनिज्म आपको याद करनी है. एंड या फाइब्रेज के साथ वन इंपॉर्टेंट वन इज मायोपैथी. ओके, when it will cause myopathy, when you give statins along with fibrates. So statins plus fibrates if given, it can cause myopathy. Cholesterol gallstones via inhibition of cholesterol 7 alpha hydroxylase, both of them very important. Okay, moving ahead, niacin, ये दो, ये normal है. Inhibit lipolysis in flushed fish is important. Hyperglycemia, hyperuricemia is important. This is important. Okay, guys, lipid lowering agents are very high yield. एक adverse effect they have asked. Okay, it is very high yield, same like diabetic medications. एक adverse effect you have to remember कौन सा drug कौन सा कर रहा है. Okay, they have never asked this PCSK inhibitor. UWorld में एक दो सवाल है, NB में एक भी नहीं है. So let's just see. Again, decrease in LDL, inactivation of LDL receptor degradation, and myalgia, delirium, neurocognitive defect. Fish oil and marine omega 3 fatty acid, ये देख लो. Yeah, it increases LDL. Okay, it increases HDL but decrease in triglyceride. तो ये mechanism. And nausea and fish like state. Okay, so lipid lowering agent में आपको सब कुछ करना है. I know mechanisms are very difficult to remember, but if you solve, you will easily find at least 5 to 6 questions regarding this only. So you have to do it. Okay, and NBME is also asked, and real exam will also ask this. Okay, moving ahead, cardiac glycoside. So cardiac glycoside में direct inhibition of sodium potassium ATPase, indirect inhibition of sodium calcium exchange. Okay, now remember one thing. They will ask you which pump affected first. So don't go for sodium calcium. Go for sodium potassium only. Okay. Positive inotropy stimulates vagus nerve, decrease in heart rate. Now what is important in this one here is, okay, let's just see. Heart failure, atrial fibrillation, because this line is very important. Decrease in conduction at AV node and depression of SA node. This is very important. Why? What is the mechanism of digoxin in atrial fibrillation? So this you have to remember. Adverse effect में nausea, vomiting normally. Yeah, one thing. Yellow vision. Yellow vision is very important. So tell me where is blue vision seen? Sharing? Blue vision कहाँ देखा था? Do you recollect?
No, I don't remember it.
नो आइडिया? याद करो ना, जनरल फार्मा में पढ़ा है इसके बारे में. Okay, I'll tell you. PDE5 inhibitors. Okay. UL में सवाल है. UL में there is question. PDE5 inhibitors will cause blue tint and deoxin is going to cause yellow vision. Alright, so make sure you know that. Can lead to hyperkalemia, which indicates poor prognosis. Factors predisposing to toxicity is renal failure, hypokalemia, then drugs that displace digoxin from tissue binding sites and decrease clearance. Example, calcium channel blockers and all this stuff. तो ये आपको याद रखने हैं. Another treatment they ask antidote to normalize K plus and anti-digoxin FeV fragment and magnesium. ये दो आपको याद रखने हैं. So digoxin becomes very high yield because one or two questions definitely are asked in UL and NBA में भी बहुत सारे हैं. Sodium potassium ATPase first, then sodium calcium. Okay, yellow vision, then atrial fibrillation में what will be the role? Then hyperkalemia, most important toxicity effect, and how you will treat it? Magnesium or give anti-digoxin FeV fragment. Okay, so all these lines are very important. Now coming to the most important and very confusing part of cardiac pharmacology, that is anti-arrhythmic. Okay, so see this graph है ना, सबसे पहले तो you have to remember this graph. Okay, you have to see कितना यहाँ पे overlap कहाँ पे हो रहा है drug के बाद. You have to see where the drug is overlapping, in which phase of conduction this drug is overlapping. Okay, because you must have seen UL and UL में they have directly given this diagram, so you have to remember that. Okay, now before we discuss this, I will give you short summary. तो short summary आप लिख लो पहले. Increase in PR interval class 2 and class 4 of antiarrhythmic. Okay, increase in QT interval class 3. तो फर्स्ट ए वाला जो है, फर्स्ट बी वाला जो है एंड फर्स्ट सी वाले जो है, यहाँ पे क्या प्रॉब्लम आ रही है? इंक्रीज इन QRS एज वेल एज इंक्रीज इन QT. यहाँ पे नो सच प्रॉब्लम. IC में इंक्रीज इन QRS. ऑलराइट, कमिंग टू एमियोडेरॉन एंड सोटालॉल. यहाँ पे क्या हो रहा है? एमियोडेरॉन में देयर विल बी इंक्रीज इन PR, increase in QRS, increase in QT. But in sotalol, increase in PR, increase in QT. So इसको याद रख लो. Okay, you must have solved UL. You must have come across these type of questions very frequently. Okay, so this is very 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 important. So याद रख लो. Another thing, if there is some problem related to the QRS interval or QT interval or PR interval, so some ions are involved over here. What are those ions? QRS will be associated with sodium, QT will be associated with potassium, and PR either beta blocker or calcium channel blocker. ऑलराइट, तो ये आपकी काफी हाई यील्ड इंफॉर्मेशन हो जाएगी. इसको याद कर लो. ओके, रिमेंबर दिस and remember the graphs that are given in anti-arrhythmic. Your all questions will be solved. Okay, write this down. I am giving you a minute. All right, so let's just discuss the classes now. Class 1A, remember the drugs. Okay, drugs, so you have to remember moderate sodium channel blockade, AP duration increase. So now clinical use में atrial and ventricular arrhythmia, they are not needed. Adverse effect. Adverse effect are important here. Synchronism, headache, tinnitus with quinidine. Okay, this they will give you in the question. Tinnitus with quinidine they will give you. Headache, tinnitus they will give you. Reversible SLE-like syndrome is important by procainamide. Heart failure, diisopropanamide. Okay, so this is very important. देखो tinnitus quinidine के साथ रिवर्सिबल एसेरियलाइक सिंड्रोम प्रोकेनामाइड के साथ, हार्ट फेलियर डायसोपायरामाइड के साथ. एंड अपार्ट फ्रॉम दिस यू हैव thrombocytopenia toss at the point due to increasing QT interval. Okay, so this adverse effect part very high. Coming to class 1B, lidocaine, phenytoin, mexaltine. Okay, now if they are asking you about class 1B, one important line they are supposed to give anything related to the post myocardial infarction. पोस्ट मायोकार्डियल इंफार्क्शन के रिलेटेड आपको पूछते हैं विच एंटी एरिथमिक यू शुड गिव, गो फॉर क्लास 1B. एग्जांपल्स आर हियर. ओके, यहाँ पे एडवर्स इफेक्ट ये है कि देयर विल बी कार्डियोवास्कुलर एंड रेस्पिरेटरी डिप्रेशन. ओके, so this is very important. पोस्ट एमआई के बारे में आपको कुछ भी पूछते हैं ना, so make sure you know this. so 1 है हमने आगे लिखा इंक्रीजिंग क्यूआरएस, 1B में कुछ नहीं. कमिंग टू 1C, 1C में it will increase QRS as well as QT will be normal. यही लिखा, QRS ही इंक्रीज होता है, QT will be normal. Now यहाँ पे remember the drugs, remember this diagram, and what else you need to remember is this, especially post MI this also nothing you have to remember here. Okay, just remember strong sodium channel blockade, moderate sodium channel blockade, वीक सोडियम चैनल ब्लॉकेज. ओके, और स्ट्रॉन्ग मॉडरेट वीक आप देख ही सकते हो इसमें कितना डिस्प्लेसमेंट हो रहा है बेस्ड ऑन द स्ट्रेंथ. ओके, सो दिस इज ऑल यू नीड टू रिमेंबर फॉर एंटी एरिथमेटिक टाइप 1. ऑलराइट, नाउ कमिंग टू टाइप 2, दैट इज क्लास 2. मेटोप्रोलॉल, प्रोपेनोलॉल, एस्पेनोल नाम याद रखो, important. Decrease SA and AV nodal activity by decreasing CAMP and calcium current. Suppress abnormal pacemakers by decreasing slope of phase 4. Okay. Now phase 4 किसका? We saw this in the physiology. There are two types of depolarization curve. One is the normal myocytes का, and another one was the SA node or AV node वाला. Okay. So AV node particularly sensitive, increase in PR interval. And adverse effect में impotence is important, exacerbation of COPD and asthma is important, may mask the signs of hypoglycemia, metoprolol can cause dyslipidemia, and another thing is that's it. Okay, that's it. तो ये मैकेनिज्म याद रखना and this 3 to 4 side effect. Yeah, of course ये डायग्राम भी याद रखना. Okay, moving ahead, class 3, amiodarone, ibutylite, dofetilide, sotalol. तो क्लास 3 में व्हाट यू नीड टू रिमेंबर, हमने लिखा ही है आगे, एम्योडेरॉन और सोटालॉल का लिखा है. तो एम्योडेरॉन क्या करता है, तीनों इंक्रीज करता है, बट सोटालॉल इज गोइंग टू इंक्रीज ओनली पीआर एंड क्यूटी. सोटालॉल हैज नो रोल ऑन क्यूआरएस, रिमेंबर दिस थिंग. ओके, so let's just see. Increase in AP duration, ERP, QT interval. Remember this diagram. Yeah. Now one thing, when you use amiodarone, check PFT, LFT and TFT, thyroid, lung and liver. Direct questions आए हुए हैं in you world. They will say amiodarone was used. So before amiodarone, what you need to check for? Lung, pulmonary, liver and thyroid function test you have to check out. Adverse effect, सोटालॉल जो है टॉर्चर द पॉइंट कराता है, एंड इब्यूटिलाइट जो है टॉर्चर द पॉइंट कराता है. एम्योडेरॉन, नाउ यू हैव टू रिमेंबर अबाउट एम्योडेरॉन, pulmonary fibrosis, hepatotoxic, thyroid disorder. Then another one is blue gray skin deposit resulting in photodermatitis. तो यहाँ पे blue gray. Okay, so that's it. So each and every class I have already mentioned you differently. तो ये अगर आप याद कर लोगे ना, आपके क्वेश्चन सॉल्व हो जाएंगे. अपार्ट फ्रॉम दिस यू नीड टू रिमेंबर द साइड इफेक्ट इन ईच एंड एवरी क्लास. ओके, साइड इफेक्ट तो आपको देख के याद करना है, एंड अलॉन्ग विद दैट ग्राफ. एंटी एरिथमिक आर वेरी 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 हाई. ओके, class 4 calcium channel blockers आते हैं. Decrease in conduction velocity. If in the question they will give you drug was given which decrease the conduction velocity, your answer will be calcium channel blocker. Okay, CCB का भी मैंने लिखवाया हुआ है, ये रहा. PR इंटरवल इंक्रीज करेगा, अगर PR इंटरवल में कोई चेंजेस आ रहा है it will be associated with CCB और बीटा ब्लॉकर. Okay, they have given here PR interval. Prevention of nodal arrhythmias. Example SVT. If in the question they ask you about SVT, supraventricular tachycardia, think about calcium channel blocker is the treatment. Okay. तो एडवर्स इफेक्ट हमने उसमें ही देख लिया कैल्शियम चैनल ब्लॉकर. रिमेंबर दिस ऑल्सो. ऑलराइट. Coming to the another type of drug that is adenosine brings potassium out of the cells, hyperpolarizing the cell and decreasing calcium current, decreasing AV node conduction. Very important. Drug of choice in diagnosing or terminating certain forms of HVT. Very short acting. Effect blunted by theophylline and caffeine. Adverse effect flushing, hypotension, chest pain, sense of impending doom, bronchospasm. High yield. युगल में एक सवाल है. I think 1 to 2 questions are there in युगल. So it become high yield. Okay. Ivabradine. Just remember the mechanism. Funny sodium current को inhibit करेगा. Just mechanism. All right. So I think with this we are done with the cardiac pharma and patho what we are remaining. Now we will move on to the vasculitis that I told you we'll discuss with the cardiovascular system. But before that, I want to write down few important points regarding CVS. जो जो रह गया है, write it down. In the question, if they say furosemide was given, furosemide is a loop diuretic. Furosemide was given plus in spite of giving furosemide, there was still overload. Okay, furosemide के बाद भी पानी निकला नहीं, didn't come out of the body. Now next, what next step you will be doing is just a minute. My screen got just a minute. All right. So yeah, I was saying furosemide was given plus even after giving furosemide, it was still overload condition. So what is the next step that you will give? Next step answer will be spironolactone. Okay, this was asked in NBME. Another thing, if in the question they say loud P2, okay, we have omitted the splitting part, splitting of heart sound. So splitting of heart sound, they won't focus here. Okay, but in the question they will give loud P2 was heard. So your diagnosis will be pulmonary arterial hypertension. Okay, PAH. Loud P2 में pulmonary arterial hypertension. Another thing, yeah, I'm writing over here. Neonate plus supravalvular aortic stenosis. Williams syndrome. Okay, Williams syndrome. Then, yeah. Another thing, कहाँ लिखूं? I'm writing over here. AV fistula. It also gives machine-like murmur. Okay, machine-like murmur PDA का भी होता है. Okay, but what is the difference here? There will be given a trauma situation also, like surgery or accident or something like that. Most common surgery देंगे. There is a trauma, and after that you are hearing the machine-like murmur. Your answer will be AV fistula and not PDA. Okay, so this is important. And the last point that I wanted to write down is left ventricular hypertrophy. Now they have asked about the genetic defects over here. So C June increases increase in beta myosin and increase in endothelin. I think this is a question of you were like us. Out of nowhere this question was asked. So I think you should know it to note down kar lena. So these are the few important points that I wanted you to note down. And that's it for cardiology. We will now focus now shift to vasculitis first. Vasculitis के बाद we will start reproductive system. Okay, so vasculitis open कर लो. All right. So let's begin vasculitis. Large vessel vasculitis, medium vessel vasculitis, and the next one is small vessel vasculitis. You have to remember which vasculitis falls under what vessels. Okay, you have to remember this. So let's just see. Large vessel vasculitis, that is giant cell temporal arteritis. So first of all, they will give it a female greater than 50 years age, unilateral headache, possible temporal artery tenderness, and jaw claudication. First, let's just underline what is important. Then I'll give you a case. May lead to irreversible blindness due to optic neuropathy associated with polymyalgia rheumatica. Most common affect branches of carotid artery, focal granulomatous inflammation, ESR increase, treat with glucocorticoids prior to temporal artery biopsy to prevent blindness. See, each and every point is important. Now, how the case will be presented to you? They will say a female with 50 years of age, and any two things will be given to you in the question. Everything won't be given. Okay. And what is very, very high yield in terms of vasculitis, you should be remembering which artery will be affected. Second, inflammation is granulomatous or not. Third, the symptoms and the age. 50 years से ज़्यादा है. So, and if they are saying headache and blindness और jaw pain, ये तीन चीजें दी रहेगी. Headache, blindness, and the next one will be jaw pain. Okay, so you have to keep in mind this is talking about the giant cell temporal arteritis along with granulomatous inflammation, carotid artery. That's it. Okay, very important. Most commonly asked. Most commonly asked. Okay, moving to Takayasu arthritis. यहाँ पे age less than 40, but in giant cell greater than 50. Age you have to pick out so that you can differentiate. It is a pulseless disease, weak upper extremity pulses, fever, night sweat, arthritis, myalgia, nodules, सब कुछ है इसमें. Okay, यहाँ पे भी granulomatous thickening and narrowing of aortic arch. Okay, aortic arch. Treatment is same. So see, mostly everything will be same. Same आएगा. I am repeating again, there will be same presentation. इन दोनों का सेम प्रेजेंटेशन आएगा, but you have to look at the age and you have to look at the artery. Here it is aortic arch, whereas in giant cell temporal arteritis it is carotid artery. Okay, so this is how you will be distinguishing between Takaichu and giant cell temporal arteritis. Moving to the medium vessel arteritis, first one Burger disease, another name is thromboangiitis obliterans. Remember both the name. Heavy tobacco smoking, males less than 40. Okay, intermittent claudication may lead to gangrene, auto amputation of digits, Raynaud phenomenon. So now important one. Segmental thrombosing vasculitis with vein and nerve involvement, smoking kisses. So यहाँ पे what you have to remember is you have to remember segmental thrombosing vasculitis with vein and nerve involvement. Second point, they will give you heavy smoker, and third they will give you amputation or else they will give you claudication. Okay, so these 3 points they will be giving you. Okay, पढ़ के ही पता चल जाना चाहिए what type of vasculitis they are talking about. Okay, vasculitis are very easy and good to score. They are score boosters. इसमें गलती नहीं होनी चाहिए. Okay, they are score boosters. You don't have to apply any logic, nothing, just the information. Okay, moving ahead, Kawasaki disease. Kawasaki disease less than 4 years. तो यहाँ पे क्या प्रॉब्लम आएगी? There will be conjunctivitis, there will be rash, स्ट्रॉबेरी रैश होगी मोस्टली, स्ट्रॉबेरी टंग होगी, एडिनोपैथी, mostly cervical adenopathy, and there will be hand foot changes and fever. Now see how the case will be presented to you. There was a lymphadenopathy, so posterior lymphadenopathy बोलेंगे ये लोग. Why posterior lymphadenopathy? Because they have said cervical lymphadenopathy. So mostly posterior lymphadenopathy they will use. They will use strawberry tongue, they will use conjunctivitis, and they will say that erythema on the hand and foot. ऐसे बोलेंगे वो लोग. Okay, now here you have to remember coronary artery. Coronary artery you have to remember. Okay, and treatment is IV immunoglobulins and aspirin. Aspirin is exception over here. We don't use aspirin with viral infections. Okay, it causes Raynaud syndrome. So Kawasaki, conjunctivitis, strawberry tongue, hand foot disease, posterior lymphadenopathy, coronary artery का problem. Okay, moving to polyarteritis nodosa. Polyarteritis nodosa में you have to remember hepatitis B. You have to remember abdominal pain, hypertension, सब कुछ होगा यहाँ पे. There will be no lung involvement. There will be no lung involvement, and this is very important. Okay, बाकी सब कुछ होगा. And if it is given hepatitis B, they will give HBsAg positive. Directly go for polyarteritis nodosa. Okay, now let's see. Renal and visceral vessels, not pulmonary arteries. So lungs को they will avoid. बाकी सारी को problem होगी. Different stages of transmural inflammation with fibrinoid necrosis. This is very important. These two lines very important. Okay, string of pulse appearance. That's it. तो वापस बता देता हूँ, polyarteritis nodosa, hepatitis B, they might give you. All other systems problem होगी except pulmonary system. Okay, fibrinoid necrosis वाला कोई vasculitis आता है, polyarteritis nodosa. All right, done. So that's it for medium and large vessel. Now we will go to the small vessel. Behcet syndrome. They never ask, but let's just see what is important over here. Recurrent aphthous ulcers, genital ulceration, uveitis. Okay. Immune complex vasculitis and HLA B51. इतनी याद रखनी है. One question in UL. बाकी NBME hasn't asked any question related to this. All right. If they are asking about aphthous ulcers and they give you some type of vasculitis occurring, think about Behcet syndrome. Cutaneous small vessel vasculitis. Ignore. This is the main deal. First one, eosinophilic granulomatous with cholangitis. Okay. इसका दूसरा नाम क्या है? Can anyone tell me what is the another name? Okay, यहाँ पे दिया ही हुआ है. Church-Strauss syndrome. Church-Strauss syndrome. They won't give you this name. They will give you Church-Strauss syndrome. Okay. देखते हैं इसमें क्या है. Asthma, sinusitis, skin, neuropathy can involve heart, GI, kidneys, everything. So everything is occurring over here. It is eosinophilic. So there has to be asthma and allergy. Okay. Nose involvement hai, and everything is there. Remember like this. Nose involvement and everything. Let's just see. granulomatous necrotizing vasculitis with eosinophilia. This is the pathology. Okay, and this is the lab value MP ANCA positive. Okay, तो ये आपको याद रखना है. Coming to granulomatous with polyangiitis, upper respiratory tract, perforation of nasal septum, chronic sinusitis, otitis media, and mastocytis. Now, what is the problem over here? Eosinophilic में there will be allergy. Nasal involvement दोनों में. There is nasal involvement in both of them. But there is kind of asthma allergy in the eosinophilic वाला church frost में. But in granulomatous with polyangiitis, asthma allergy नहीं होगा. There will be actual nose problem, nasal bone problem और sinusitis, septum problem. Okay. बाकी सब तो common होगा सब में. One important thing, there will be hematuria and hemoptysis because it will be associated with just a minute. Yeah, it is vaginal granulomatosis, and we have done this in, I think, RPGN, rapidly progressive glomerulonephritis. Okay, so इसमें ट्रायड देखते हैं. Necrotizing granulomas present, focal necrotizing vasculitis and necrotizing glomerulonephritis, RPGN. Okay, यहाँ पे भी आपको CN का याद रखने हैं. You have to remember the name in bracket also. Here also remember the name in bracket. They have not given the name in bracket over here. So CN का is antiproteinase और CN का I actually don't remember अभी. Anti-myeloperoxidase. Anti-myeloperoxidase. Okay, so remember like this. So I hope you got the difference between Church straws and vaginal. एलर्जी वाला आया तो चॉक स्ट्रॉस, एलर्जी नहीं आया तो वेजिनल. Another thing, both of them is having granulomatous inflammation. Third, in church straws there will be P ANCA, whereas in vaginal there will be C ANCA. Fourth, church straws में एलर्जी अस्थमा है so IgE increase, eosinophils increase, whereas vaginal में no such problem. All right. Moving on to immunoglobulin A vasculitis, the name over here is Henoch-Conlin purpura. Very important. Okay. So it follows upper respiratory infection, classic triad, hinge pain, stomach pain, palpable purpura on buttocks and legs. Buttocks and legs very important. They will actually, how they will give you the cases, they will give you a small baby, not small baby, infant, and they will give you a naked buttock. Okay, उनके naked buttock देंगे and they will give you. Okay, I'm changing the color so that it becomes easier for you. This is the baby and they will give you red dots. Okay, on the whole buttocks and legs. Okay, if they are giving this image, strictly think about Henoch-Conlin purpura. Okay, so IgA है, so IgA nephropathy होगी. Burger disease that we did in IgA nephropathy. That's it. तो आपको याद रखने हैं, there can be arthralgia, there can be stomach pain, and there will be purpura. So this is Henoch-Conlin purpura. All right. Moving to microscopic polyangiitis. Now, what is the problem here? Confusing with Church straws, vaginar. How you will distinguish this? No nasal involvement. Church straws में एलर्जी अस्थमा और वो था. वेजिनर में there was nasal problem, interventricular septum problem like that. Whereas microscopic polyangiitis में no nasal involvement. So यहाँ पे बाकी सब organs में problem होगी but no nasopharyngeal involvement. Okay. So P ANCA. Another important distinguishing feature, no granulomas. Vaginal and church straws में granulomas है, यहाँ पे no granulomas. All right. So P ANCA positive. That's it. All right. That's it. And coming to the last one, mixed cryoglobulinemia. They will give you HCV present. Okay, HCV positive they will give you. And another thing that I have to remember here is cryoglobulins are immunoglobulins that precipitate in cold vasculitis due to IgG and IgM. So they have to give you HCV and purpura, weakness, arthralgia. Okay, this is not commonly asked, but you will में एक question है. You बाकी mark my word, vasculitis are very easy. Yeah, another thing I want you to remember here is ये भी देख लेना आप सी एन का और पी एन का कैसे दिखते हैं. ओके, सी ग्रेनुलोमेटस इन्फ्लेमेशन कैसे दिखते हैं. ओके, सो आई होप you are clear with the vasculitis part. Very important and very easy. एक बार ब्रीफ समर अप दे देता हूं मैं. इफ दे आर टॉकिंग अबाउट द चर्क स्ट्रॉस सिंड्रोम, इट मींस उसमें इयोसिनोफिल्स का मतलब अस्थमा एलर्जी विल बी प्रेजेंट. ओके. इफ दे आर टॉकिंग अबाउट वेजिनार ग्रेनुलोमेटर वेजिनार सिंड्रोम, तो वेजिनार ग्रेनुलोमेटस में क्या होता है, there will be no allergy. Nasal involvement होगी, but it will be nasal septum defect और sinusitis, all those. Okay. थर्ड, माइक्रोस्कोपिक पॉलीएंजाइटिस. माइक्रोस्कोपिक पॉलीएंजाइटिस में नेजल इन्वॉल्वमेंट नहीं होनी है. ओके. अंडर डिफरेंस ऑफ माइक्रोस्कोपिक पॉलीएंजाइटिस देयर विल बी नो ग्रेनुलोमा, बट ग्रेनुलोमा विल बी प्रेजेंट इन चर्क स्लॉट एंड वेजिना. ओके. ये तीन का डिफरेंस हो गया. कमिंग टू आईजीए वेस्कुलाइटिस, दैट इज हेनोस्टोनलिन पर्प्यूरा. व्हाट दे विल शो यू अ नेकेड इन्फेंट विद बटक्स एंड लेग्स, और उसमें रेड रेड पर्प्यूरा होंगे. ओके. दैट्स इट फॉर स्मॉल वेसल वेस्कुलाइटिस. ऑलराइट. एंड बाकी जो लार्ज वेसल और मीडियम वेसल है, हाउ टू डिस्टिंग्विश, रिमेंबर द आर्टरी, डिफरेंट आर्टरी. ऑलराइट. So I think with this we are done with our CVS section. So if you have any doubt, ask me, and let's just take a 5 minute break and we will start with the reproductive part. Alright, that's it. All right, let's start our next system. Okay. All right. So, guys, reproductive system is a system in which you have to focus more on physiology and embryology. Okay. So, reproductive में we will be focusing today on embryo and physio. Tomorrow we will focus on patho and pharma. Tomorrow we'll finish the reproductive also, and on Saturday and Sunday we'll finish micro. Okay, mostly on Saturday only I am planning to take the class on morning and evening. So एक दिन में ही माइक्रो हो जाएगा तो अच्छा है. तो by Saturday we'll finish our course. Hopefully today we'll finish the embryology and physiology of reproductive. Okay, let's just start. Yeah, first one. The genes are very important. H double H. We saw this in the holoprosencephaly earlier in the CNS system. Okay, so here what you have to remember is you have to remember the notes part also you have to remember and the function also. Okay, actually one or two questions were there in UL regarding this. They asked about the function. Okay, so अगर UL ने पूछा है तो definitely you have to focus. Okay, so anterior posterior axis patterning CNS development SSH. फिर आता है WNT zone dorsal ventral axis. फिर आता है fibroblast growth factor, limb lengthening and that is limb lengthening का fibroblast and homeobox gene, segmental organization in cranial caudal direction, transcription factor coding, mutations, appendages in wrong location. Okay, so appendages in wrong locations, how they are presented in UL is polydactyly, syndactyly. Okay, so this is how you have to remember the gene. H double H का आपको holoprosen से पहले याद रखना है. Fibroblast growth factor का you have to remember that helps in the limb lengthening, increasing size of the limb. Homeobox you have to remember the at long appendages at wrong location. You have to remember this. Okay. Now moving to the fetal development. First, पहले आप इसको ध्यान से पढ़ना. They will ask you basic things like morula कब होता है, implantation कब होता है, all those basic stuff they like to ask. Okay, so see, and if you have studied OB/GYN perfectly, if you have studied OB/GYN properly, this system is a cakewalk for you. But when I was preparing, I didn't do OB/GYN. I was in the fourth year. Okay, so OB/GYN तब था नहीं मुझे. So I faced really difficulties while solving this chapter. But if you have studied OB/GYN at least once, you will be good to go to this system. Okay, so देखते हैं. वीक वन में एचसीजी सिक्रेशन बिगिन. वीक टू में बाइलैमिनार एम्ब्रियोनिक डिस्क. वीक थ्री में ट्रायल लैमिनार. ओके, वीक फोर में हार्ट बिगिंस टू फॉर्म. वीक एट में जेनिटेलिया बिगिंस टू फॉर्म. वीक 10 नहीं दिया. ऑल राइट, सो राइट डाउन वीक 10. दे डिडंट इवन गिव वीक 6. वीक 8. वीक 8 तो दिया हुआ है, बट दैट इज ऑल्सो डिफरेंट ओवर हियर. Let me just see आगे कहीं तो नहीं दिया है. No, they haven't given here. So it is in the old edition. So write down few important points that I want to write. Week 10, week 15. So let's just see. Week 6 में क्या होता है? Fetal cardiac activity, heard or visible in transvaginal ultrasound. Okay, वीक 8 में fetal movement start. वीक 10 में, here they have given in week 8, but in old edition it is week 10. So we will follow week 8 only because it is a new edition. Okay. Generally, I have male female characteristics, so we'll follow the new edition only. Okay. One important point, week 3 to 8. Sorry, not 3 to 8. Week 3. Week 3 में there is organogenesis. Okay, it means कि यहाँ से organs बनना शुरू हो रहा है. Organogenesis. So as a result, it is most teratogenic week. Okay, so you need to be careful with all the drugs that you are giving. You need to avoid all the teratogenic drugs. Okay, so week 3 is very important. And yeah, काफी कुछ change हुआ है this edition में. I don't like it. The old edition was very good. काफी कुछ information थी that was helpful, but I don't know why they changed this. So yeah, and week 15 से बाद से there is gender detection. Okay, so these are the few important points that you have to remember in embryonic development. आगे देखते हैं. Now one important point I would like to tell you is ये जो पार्ट है ना, प्रिंट आउट निकाल के चिपका दो. You are not going to remember this. Okay, कितना ट्राई कर लो ये याद ही नहीं होने वाला unless you solve more and more questions and you look at it continuously. Okay, this is very high yield, and they have asked so many questions. They have given the structure, they have asked for diagnosis, and then they have asked the structure that is affected over here, the organ that is affected over here is derived from which, germ layer. Okay, so soft ectoderm, mesoderm, endoderm. Soft ectoderm में दो, neural tap, neural tube and neural crystal. Very important, सवाल पक्के आएंगे. Okay, so just see over here. ये सारे नाम you should remember. All the names are very important. I know I am marking everything, but what to do? You have to remember each and everything. Alright, ये आपका यहाँ पे hint दिया हुआ है. Okay, so जितना हो सके ये पेज को बार बार देखो. Take the printout, stick it in front of you. उठते बैठते खाते पीते देखते रहो. Alright, because it is the only way you will be doing this question correct. And believe me, so many questions are there in NBME also, in UWorld also, in exam also I was asked. Okay, so this is very high yield. Do it properly. Coming to teratogens. Teratogen. So either ACE inhibitors or along with that I will add ARBs. So ARBs में देखते हैं renal failure, oligohydramnios being most important. That is Potter's syndrome. Okay, we have done this. Potter's syndrome. Coming to alkylating agents, aminoglycosides में autotoxicity याद रखना. Anti-epileptics में neural tube defects you have to remember. Then in diethyl जो DES है, तो यहाँ पे vaginal clear cell adenocarcinoma. Fluoroquinolones में cartilage damage. Folate antagonists में neural tube defect. And another one what you have to remember, warfarin में bone and cartilage deformity. Then tetracyclines में discolored teeth. Methimazole में aplasia cutis. Lithium में epstein anomaly. So this one effect on fetus you have to remember. Substance use, alcohol किया तो fetal alcohol syndrome. Cocaine, so preterm birth, low birth weight. Tobacco, preterm birth, low birth weight. Okay. Other, lack of iodine or excess of iodine, there will be congenital hypothyroidism. Maternal diabetes है तो caudal regression syndrome. Now what are the features over here? This is very high yield. NBME has asked and even UWorld has asked. Okay, so cardiac defects होंगे पहले. Then neural tube defect, macrosomia, there will be a big phase. Neonatal hypoglycemia due to islet cell hyperplasia, this is very important. Okay, very important. Maternal PKU, fetal growth restriction, microcephaly, intellectual disability. That's it. That's it. Okay. So ये सारे teratogenic है ना? This already you have studied somewhere or other. So this is just a brush up for you. Okay. So as I told you, reproductive system में you have to focus on embryo, physio more along with pathology. Okay. So let's just see. आगे बढ़ते हैं. This is very weird, but you will ask this. They will give you the conditions. Okay. They will give you the conditions, and then they will ask what is the morphology agent is occurring over here. Okay, this is very weird. You will just ask this so many questions, and every time I used to do it wrong. So you also do this properly. Okay, fetal alcohol syndrome. Whenever there is a fetal alcohol syndrome, now always look for two, three things. Okay, what is that? First one, developmental delay and microcephaly. This is the first one. Second is facial abnormality, smooth plethrum, thin vermilion border, small palpable fissure, fat, flat nasal bridge. Any one of these they will give you in the question, and this is very important. Okay, fetal alcohol syndrome ये बहुत important है, and they will actually describe any one of them. Okay, so holoprosencephaly may also occur. Alright, so ये आपको याद रखने हैं. Now, what is the meaning of all those stuff? I'll write it down for you. Plectrum, groove from base of nose to upper limb. ये प्लेथ्रम जो है ना इसका thin vermilion border is upper lip. Small palpebral fissure is small opening of eyes. Okay, और fourth तो आपको पता ही है. Alright, so this is all you have to remember in fetal alcohol syndrome. Many questions have been asked and these symptoms are given. Okay. Neonatal abstinence syndrome, complex disorder involving CNS, ANS, and GI system. Newborn may present with uncoordinated sucking reflex, irritability, all those stuff. So that's it. So universal screening for substance use. Okay, agar one classic case that they give over here is neonate feels irritated. Okay, if in the question they are saying that the small newborn baby or the neonate is feeling irritated, then think about substance abuse in mother. Okay, the small one word you have to remember. And another thing is that's it. All right, that's it. Just remember what is cytotrophoblast, sensitive trophoblast, and that's it. Nothing else you have to remember. Just ignore this. This is amniotic fluid, polyhydramnios and oligohydramnios. This we already did in the renal system. Polyhydramnios, too much amniotic fluid, idiopathic associated with fetal malformation, esophageal duodenal atresia, and encephaly. Okay, both result in inability to swallow amniotic fluid, diabetes, fetal anemia, everything you have to remember. Okay, they won't ask more in detail about polyhydramnios, but they will definitely ask about oligohydramnios. We have done this in renal. Go back over there and revise it. Okay, moving ahead. Twinning. Now in twinning, only one question has been asked in UL. Okay, so just remember this. They have asked about the days. Okay, they have asked about this. So just इतना याद कर लो, बाकी कुछ भी करने की जरूरत नहीं है. Don't go into detail over here. Okay, only one question in UL. NBM has never asked, and I think exam is also not asked. Moving ahead, umbilical cord. From here, the actual embryology starts. So many questions will be coming from here. Okay, just a minute. Hmm. This line is important. Two umbilical arteries return deoxygenated blood from fetal internal iliac arteries to placenta. One umbilical vein supplies oxygenated blood from placenta. And this information is important. Okay. So if you can remember, try to remember this diagram. Moving to the urachus. Yuval has asked, NBME hasn't asked. Okay, Yuval has asked. So let's just see. Allantois forms from yolk sac and exchange into cloaca. Intra-abdominal remnant of allantois is called urachus. Okay, a duct between fetal bladder and umbilicus. Failure of urachus to involute can lead to anomalies that increase the risk of infection in adenocarcinoma. Not obliterated urachus is represented by median umbilical ligament after birth, which is covered by median umbilical fold of peritoneum. Each and everything is very high yield from the Yuval point of view. Okay. Coming to patent urachus, now we will be studying the disorders of urachus. So patent urachus is total failure of urachus to obliterate urine discharge from umbilicus. They will give you this symptom: urine discharge from umbilicus. Urachal cyst. So cyst can become infected and present as a painful mass below umbilicus. Okay. Partial failure of urachus to obliterate. And vesico-urachal diverticulum, slight failure of urachus to obliterate, outpouching of bladder. So these three symptoms that they have given here: discharge from umbilicus, painful mass below umbilicus, outpouching of bladder. So these three things is what will help you to diagnose this condition. Okay. NBME point of view say not important, but you will make so many questions are there, so you have to keep this in mind. Coming to vitelline duct, also called omphalomescentric duct. Okay, obliterate during the week 7 of development. Now we have done the macal diverticulum in GIT. Slight failure of vitelline duct to obliterate, outpouching of ileum is a true diverticulum, and we know what all history is there with macal diverticulum. Coming to patent vitelline duct, total failure of vitelline duct to obliterate, meconium discharge from umbilicus. Be aware of the differences about meconium discharge from umbilicus, urine discharge from umbilicus. Okay, if it is urine discharge, has to be a urachus. If it is meconium discharge, it has to be vitelline, patent vitelline duct. Coming to vitelline duct is partial failure of vitelline duct to obliterate, increased risk of forward. Okay, so I think both of them are same only, just the terms are different regarding urachus and vitelline duct. All right, so I hope this is clear. Again, both of them are important from the UL point of view and BME agenda. Okay, moving again to pharyngeal apparatus. Now, one more thing they changed over here was aortic arch. Okay, aortic arches, we did this in the CVS. That was a part of reproductive. Okay, in that class I told you it was a part of CNS. No, it's not a part of CNS, it's a part of reproductive. Okay, so aortic arch ka bhi printout nikal ke I told you to stick it. Here you have to take out the printout of pharyngeal arches. Along with pharyngeal arches, you have to take out the pharyngeal pouch derivatives and even this pharyngeal cleft derivatives. Guys, these three are very important and so many questions have been asked. I know it's difficult to remember, but daily आप देखते जाओगे, questions solve करते जाओगे, it becomes easier, believe me. Okay, so let's just see. Pharyngeal apparatus consists of pharyngeal clefts, arches and pouches. So pharyngeal clefts are derived from ectoderm, pharyngeal arches derived from mesoderm, pharyngeal pouches derived from endoderm. So this is also you have to remember. Okay, moving to pharyngeal cleft derivative. First cleft derivate into external auditory meters, that is ear canal. Second through fourth cleft from temporary cervical sinuses which are obliterated by formation of second, not necessary. Pharyngeal cleft cyst, persistent cervical sinus present at the lateral neck mark anterior to sternocleidoid muscle that does not move with swallowing. So pharyngeal cleft cyst is important. Okay, यहाँ पे क्या था pharyngeal cleft cyst? Yeah, persistent cervical sinus, that is important. It is also known as branchial cleft cyst. So अगर branchial cleft cyst आ रहा है, don't get confused. Okay, it is on the lateral side, thyroglossal duct on the middle side, and cystic hygroma is on the posterior side. Okay. Another thing that I wanted to remember is, yeah, first cleft develop into external auditory meatus, that you have to remember. Okay, ये याद रखना है. All right, so that's all about pharyngeal cleft derivatives. Coming to pharyngeal arch derivatives. Okay, now see, they have already given this rhyming line over here. Children tend to first chew, then smile, then swallow stylishly, or simply swallow and then speak. These are the hint. Okay, so देखते हैं first pharyngeal arch, third branch of trigeminal nerve. Third branch of trigeminal nerve है मतलब muscles of mastication. Okay, lateral and medial pterygoid, mylohyoid, and another thing is anterior two-third of tongue. Okay, anterior two-third of tongue. We saw all the tongue supply in the CNS. Okay, so ये सारे आपको याद रखने पड़ेंगे. Along with that, कार्टिलेज, कौन कौन से कार्टिलेज इट विल सप्लाई? मैक्सिलरी प्रोसेस, मैक्सिलरी जाइगोमेटिक बोन, मैंडिबल, मेलियस, इंकस, सब कुछ याद रखना है. ओके, आई एम सॉरी, but this you have to remember. I don't have any way like how I can teach you to remember. Okay, but see one thing is, फर्स्ट और सेकंड में ना कार्टिलेज का इतना इश्यू नहीं है. ओके, सो फर्स्ट और सेकंड में आप अवॉइड कर सकते हो. In the old edition, what they gave here was nerves. Instead of cartilage, they gave nerves. Okay, so nerves may this, and in second pharyngeal, the facial nerve. Okay, so एक काम करो, cartilage कर ही लो. Questions might be asked. Maxillary process, mandibular process. Okay, moving to second pharyngeal arch, it is a facial nerve का lesion. So muscles of facial expression will be gone. Cartilage में styloid process, lesser horn of hyoid, stylohyoid ligament. याद करना है. ओके, अगेन आई एम टेलिंग यू, डोंट वरी, लगा दो ऊपर एंड यू विल बी गुड टू गो. ओके, यू कांट जस्ट इग्नोर दिस, दिस इज वेरी हाई. ओके, नाउ कमिंग टू दिस टू टाइप्स ऑफ सीक्वेंस, पियरे रॉबिन सीक्वेंस एंड ट्रैकर कॉलिन syndrome. So micrognathia, glossoptery, cleft palate, airway obstruction. Now how you will remember here is, if they have given micrognathia means small mouth and cleft palate, think about Pierre Robin. And about Treacher Collin, they will give you neural crest dysfunction, so craniofacial abnormalities. Most common is hearing loss and zygomatic bone. So zygomatic bone and hearing loss, if they have given, think about Treacher Collin syndrome. Not very high yield, but this is very high yield. Pierre Robin sequence is high yield. Okay, so first or second में, first में there is a trigeminal nerve, second में there is a facial nerve. Muscles, so you will be easily able to remember. Problem will be in cartilage. How you will remember? Watch it daily. Okay, coming to the third pharyngeal arch, there is glossopharyngeal nerve. Okay, fourth and sixth, fifth arch is not developed. Okay, so you will go to fourth and sixth. So fourth and sixth में पहले fourth का देखते हैं. Cranial nerve 10, superior laryngeal branch, and cranial nerve 10, recurrent laryngeal branch. Okay, so swallow and speak दोनों involve होगा यहाँ पे. Fourth arch and sixth arch. Here important thing is, all intrinsic muscles of larynx except cricothyroid. Okay, and here most pharyngeal constrictors, cricothyroid, levator, velli, palatine. So fourth arch में सारे, sixth arch में all except cricothyroid. This is very important and high yield. अगर cartilage के हिसाब से आप जा रहे हो, so they mostly ask about the fourth and sixth pharyngeal arches, mostly, but you can't avoid all those. Sometimes they ask that also. Okay, so you have to remember this. And arches 3 and 4 form the posterior one third of tongue. 5 makes no major development. So guys, I am marking this again and again. Very high yield है. Again and again you have to keep looking over here, so that जितना देखते जाओगे उतना याद होता जाएगा. All right. Moving to the pharyngeal pouch derivatives. Again I am repeating the same thing. Print out निकालो, चिपकाओ, जितनी बार देखोगे उतना important है. Okay. बहुत important है ये, very important. Let's just see first pharyngeal pouch, middle ear cavity, eustachian tube. First pouch contributes to the endoderm line structures of ear. Okay. Second pharyngeal pouch, palatine tonsils. Palatine tonsils is important. Third pharyngeal pouch में inferior parathyroid, dorsal wing, inferior parathyroid, and thymus also. Okay. Third pouch contributes to thymus and both inferior parathyroid. Okay. And fourth pharyngeal pouch is superior parathyroid and parafollicular C cells of thyroid. So again I am telling you, ये important है. Okay, so either you make your own notes and stick on the wall, or you take the printout from this page of first aid and put it on the wall. It's completely up to you, but you have to do directly. याद किया हुआ information है, so it is a score booster. You don't have to apply any application, don't have to apply any logic. All right, so daily देखते रहो, याद हो जाएगा. Orofacial cleft, and this is very high yield because they ask is cleft lip में failure of fusion कहाँ पे हो रहा है? What is the failure of fusion in cleft lip? So due to failure of fusion of intermaxillary segment with maxillary process. Okay, so medial nasal process. Okay, this is important. And cleft palate में due to failure of fusion of two lateral palatine cells or the failure of fusion of lateral palatine cells with nasal septum. Okay guys, so many questions have been asked. NBME as well as UWL. You have to remember this failure of fusion. That's it, और कुछ भी नहीं. So that was all about the basic embryology, pharynx ka development, every week development of a baby and all those stuff. Now we'll go to the genital embryology, female, male. Okay, this is all the basic stuff that you study, I think, in the early physiology and embryology class. काफी basics है how the development is occurring from the genitourinary period. Okay, so देखते हैं female. Mesonoptic duct degenerates and paramesonopic duct develop. And on male, SRY gene is responsible, produces testis determining factor, testis development. Okay. Sertoli cells secrete Mullerian inhibitory factors that suppress development of paramesonopic duct. Very important. Leydig cells secrete androgens that stimulate development of mesonopic duct. Each and every line very important because they have asked everything in detail. Okay, everything they have asked in detail, nothing to understand here, you just have to remember. Okay, इसमें कुछ भी समझाने लायक नहीं है. Coming to paramesonopic, that is Mullerian duct, develops into female internal structures. Okay, fallopian tube, uterus, proximal vagina, and if there is a Mullerian agenesis, so there will be primary amenorrhea with absent uterus, blind vaginal pouch, normal female external genitalia, and secondary characteristics. Now see, Mullerian duct जो है, paramesonopic duct, they are all responsible for forming internal structures. External नहीं, internal. Okay, so keep this in mind. And if there is a agenesis of Mullerian duct, so female external body will be normal, external development will be normal, secondary sexual characteristic will be normal, but internal structures नहीं रहेंगे. Okay, coming to mesonephric duct, develops into male internal structures, so seminal vesicles, epididymis, alveolar duct, and this. So now what they ask here is, they will say if there is a agenesis of mesonephric duct, what all structures will be not found. In paramesonephric duct, what all structures will be not found. So you have to remember the name of structures, especially in the male. They are most commonly asked because these four structures of male very difficult to remember. Okay, so basic information how it is separated into male and female. Sertoli cells responsible for Mullerian inhibiting factor. Leydig cells responsible for more and more mesonephric duct proliferation. All right, both this paramesonephric and mesonephric, they are responsible for forming internal structures in both male and female. All right, so that's it. Let's move ahead. Sexual differentiation. So before beginning ahead, I want you to remember this pathway because this pathway is what going to help you in remembering pharmacology. Okay, simple hai. Let's see, mesonephric duct and paramesonephric duct. SRY gene hai, so let it will go towards the testis. Testis से Leydig cells, testosterone and Sertoli cells will be secreting Mullerian inhibitory hormone. So ये पूरा inhibit हो जाएगा. Let's just see आगे क्या होता है. Leydig cells will secrete testosterone. So 5 alpha reductase will be going towards dihydrotestosterone. External male genitalia बनाएगा. Whereas ये जो Leydig cells से testosterone है और ये जो duct है ये internal बनाएगा. And this testosterone is also responsible for secondary sexual characteristics. Simple funda. Okay. SRY gene है. Testis आया. Testis में Leydig and Sertoli. Sertoli will be inhibiting the female part. Leydig will be going towards testosterone and forming external and secondary sexual characteristics. Mesonephric duct जो है that will be coming down and forming internal structure. Okay, that was about the male. Now let's just see female में क्या होता है. Female में what happens? Ovary, there will be first of all no SRY gene influence. Okay, so ovary है, estrogen और testosterone secrete करेगा. So estrogen एक्सटर्नल फीमेल जेनेटिलिया बनाने में हेल्प करेगा एंड ब्रेस्ट डेवलपमेंट में हेल्प करेगा. फिर ये जो सर्टोली सेल्स है जो इनहिबिट कर रहे हैं मेसोनेफ्रिक सेल, तो उसमें क्या होता है, ये तो इंटरनल जेनेटिलिया को इनहिबिट करेगा. ओके, एक्सटर्नल तो बनते जाएगा. ऑलराइट, एंड दिस टेस्टोस्टेरोन दैट इज सीक्रेटेड फ्रॉम द ओवरी दैट इज आल्सो रिस्पांसिबल फॉर द प्यूबिक एंड एक्सरी हेयर इन फीमेल्स. ओके, बाकी जो इंटरनल है that is formed by both mesonephric and paramesonephric respectively. Okay, so this is the entire summary that they have given over here, very beautifully explained. Just go through it properly. Okay, so let's just see इसमें defects क्या हो सकते हैं. Absence of Sertoli cells or lack of Mullerian inhibitory factor develop both male and female internal genitalia. Okay, 5 alpha reductase deficiency. 5 alpha reductase deficiency हो गया तो internal genitalia रहेगा but external genitalia नहीं होगा. Okay, so in the testis, Leydig cells lead to male internal and external differentiation. Sertoli cells shut down female. Completely information is simple information is given here. इसको बराबर याद कर लेना. All right. Okay. Moving ahead. Uterine anomaly. Now this is very high yield. Even in NBME, even in UWorld, and here these images are very important. Okay. Let's just see septate uterus, incomplete resorption of septum. Bicoordinate uterus, incomplete fusion of Mullerian duct. Uterus didelphys, complete failure of fusion. Double uterus. तो देखो ये याद रखना है. This is the normal. And this is what will happen in septate, bicoordinate, and uterus didelphys. Very important. Directly they will give you this image in the question. Okay. Let's move ahead. Male genital homologue. Now see, remember this because what they are going to ask you, they will give you the entire blah blah blah, and at the end they will say, they will give you this, and they will ask what is the male part and what is the female part. Okay, so ये भी याद करना है, and even this is very difficult to remember. Print out निकालो, सामने लगाओ. Okay, see you have to do this stuff because when I was preparing, I had actually 30 pages on my wall. Okay, and daily while waking up, while walking in the room, while solving UWorld also, I used to see them. Oh yeah, that is the question, that is the answer, that is the answer. Okay, so print out निकालना जरूरी है, wall पे चिपकाना जरूरी है. Otherwise, it's very difficult to mug up. So it's better if you see that information daily, daily, daily. That is the only way how you will excel in all this memorization stuff. Okay. Coming to congenital penile abnormality, this is also important. Hypospadias and epispadias. Hypospadia means abnormal opening of penile urethra on ventral fold. If this is the penis, तो यहाँ से there will be urine outflow coming. And अगर epispadias है, तो यहाँ से urine outflow निकल जाएगा. Urethral meatus is over here, right? Urethral meatus is over here. But epispadias में यहाँ से urine leak होगा, hypo में यहाँ से urine होगा. Okay, let's just see. Abnormal opening of penile urethra on ventral, abnormal opening of penile urethra on dorsal. Okay, now one important point, due to failure of urethral fold to fuse due to faulty positioning of genital tubercle. This is what they have asked in the exam. Okay, this is what they have asked. Hypospadias is more common than epispadias. Okay, associated with inguinal hernia and all those. This is not necessary, but this is only what they will be asking you. In a question, they will describe the urine is flowing from the dorsal part of the penis or the part. Okay, you can ignore this. Now coming to the anatomy part, guys. Today we will end up at the anatomy. I am tired. I can't go for physiology today. Physiopatho will do tomorrow. Okay, so anatomy कर लेते हैं. Venous drainage, lymphatic drainage. Venous drainage. Left ovary testis, left gonadal vein, left renal vein, IVC, whereas right ovary testis, right gonadal vein directly into IVC. This is very important. Because left testicular veins enters the left renal vein at 90-degree, flow is less laminar and not needed. That's one important point. Varicocele is more common on left because left has to go to the gonadal vein and all those stuff. Okay, so इतना याद रखना. Coming to lymphatic drainage, and this is high yield, high yield, high yield, high yield. 4 times मैंने high yield लिखा है तो समझ लो कितना important होगा. Why it is high yield? Because it becomes difficult to remember. Ovary, testis, fundus, para-aortic lymph node. Body of uterus, cervix, superior part of bladder, external iliac lymph node. Prostate, cervix, corpus cavernosus, internal iliac lymph node. Distal vagina and everything, superficial inguinal lymph node. Clitoris gland, many, and mark my word, everything is important. You will ask everything, NBME has asked everything. Okay, so as I told you, reproductive is a system where along with pathology, you have to focus on embryo, physio, anatomy भी करनी पड़ेगी. Okay, see everything is memorizing over here. Nothing I have to explain. I am just marking you what is high yield. Questions के हिसाब से. I have solved UL, I have solved emboss, I have solved all the NBME. So I have more idea. That's why I am saying you frequently ये सवाल आए हैं. female reproductive anatomy, you can actually avoid this. What you need to remember here is the ligament. Ligaments याद करो, connections याद करो, and vessels याद करो. Okay, vessels are very important because they will be asking you for ligation and bleeding. Okay, for example, if it is infundibulopelvic pelvic ligament, so ovarian vessels है. So they will say कि ovarian vessel ligation during oophorectomy risk damaging the ureter. तो ऐसा आएगा. In this over here, uterine vessel. So uterine vessel ligation during hysterectomy, they will ask you. बाकी ये सब आप छोड़ दो. Not necessary. Okay, remember the ligament, remember what it is collecting, and remember the vessels. Okay, in this also, if you want to go as per the high yield stuff, so high yield stuff में infundibular is high yield, cardinal is high yield, broad is high yield. That's it. These three are very high yield. All right, now adnexal toxin. Twisting of ovary and fallopian tube around infundibulopelvic ligament and ovarian ligament, compression of ovarian vessels in infundibulopelvic ligament, blockage of lymphatic and venous outflow. So what will happen here is there will be ovarian edema, complete blockage of arterial inflow, necrosis, local hemorrhage. So this is how they will be giving you. It is seen there is a mass in ovary, necrosis, and local hemorrhage seen, and there is pain plus nausea प्लस वॉमिटिंग. सो अगर ऐसा दिया हुआ है मास इन ओवरी, नेक्रोसिस एंड हेमोरेज, थिंक अबाउट एडनेक्सल टॉर्चन. मूविंग अहेड, वी हैव फीमेल रिप्रोडक्टिव हिस्टोलॉजी. नाउ सी, ये सब तो आप कर लोगे. द मोस्ट कॉमन क्वेश्चन दे लव टू आस्क इज अबाउट ओवरी. ओवरी में दे विल गिव सिंपल क्यूबॉइडल एपिथेलियम. सो अगर क्यूबॉइडल एपिथेलियम दिया है इन एनी ऑफ द रिप्रोडक्टिव पार्ट, थिंक अबाउट ओवरी. ओके, मेल्स में कुछ याद करने का जरूरत नहीं है, इसमें कुछ भी याद करने की जरूरत नहीं है. मूविंग अहेड, जेनाइटो यूरिनरी ट्रॉमा. नाउ दिस इज समथिंग न्यू दैट दे हैव एडेड हियर. तो सबसे पहले यूरेथ्रल इंजरी करते हैं. ऑलमोस्ट एक्सक्लूसिवली इन मेल्स प्रेजेंट विद ब्लड एट यूरेथ्रल meatus, hematuria, difficulty voiding. Okay, and because there is a urethral injury and difficulty in voiding and blood is present, you won't use catheterization. Catheterization is relatively contraindicated. This is very high yield point. Another thing, they will ask you the difference between anterior and posterior urethral injury. How you will remember? Based on the case. If they say straddle injury, anterior. If they say pelvic fracture, posterior. Okay, what is happening here? Disruption of bulbar urethra, and here disruption at bulbomembranous junction. Okay, what will happen over here? Urine leak into retropubic space and high riding pouch space, and here urine escapes into perineal space. तो कहाँ पे यूरिन एस्केप हो रहा है वो जानना है, लोकेशन जानना है, एंड द केस. इफ इट इज स्ट्रेडल देन एंटीरियर, इफ इट इज pelvic fracture trauma, it is posterior. It is urethral injury is important. Let's do renal injury. Bruises, flank pain, hematuria. ठीक है, renal injury पीछे है तो पीछे लात मारी होगी या मारा होगा, that is what renal injury. Bladder injury present with hematuria, suprapubic pain, difficulty voiding. Superior bladder wall injury, anterior bladder wall or neck injury. These are not been asked, so you can just give it a read. One question is there in UL, so you can avoid this. NBME ने नहीं पूछा है, एग्जाम में नहीं आया, but urethral injury very important. Okay. Autonomic innervation of male sexual response. So here they will ask you the emission of sperm, expulsion of sperm. What is responsible? Another thing, they will ask you what is responsible for erection. Erection के लिए कौन सा सिस्टम रहेगा? Okay, so you know ये वाला is responsible for erection, whereas norepinephrine it causes constriction and it is anti-erectile. तो ये आप देख लेना एक बार. Emission is by sympathetic nervous system, expulsion is by visceral and somatic nervous system. So these are small points. These are not high yield. but give it a read. Okay. Moving to the last part of our anatomy, seminiferous tubules in males. Let's just see what information you have to remember here. So spermatogonia maintain germ cell pool and produce primary spermatocyte. Line seminiferous tubule. Okay, not important. Sertoli cells and Leydig cells high yield. ऑलरेडी हमने आगे इसके फंक्शन देख चुके हैं, बट यहाँ पे विल बी डूइंग मोर. Secret inhibin B inhibit FSH. This is very high yield point. Inhibin B decreases FSH. Secret androgen binding protein maintain local levels of testosterone. Another high yield. Produce Mullerian inhibiting factor. So you know कि Mullerian duct को inhibit कर देगा, female external duct नहीं बन, external structure नहीं बनेगा. Tight junction between adjacent Sertoli cells form blood testis barrier, isolate gamete from autoimmune attack. Another important point. Sertoli cells support and nourish developing spermatozoa, regulate spermatogenesis. Temperature sensitive, decrease in sperm production and inhibin B with increasing temperature. ओके, इनिबिन बी डिक्रीज हो गया तो एफएसएच इंक्रीज हो जाएगा, और इनिबिन डी बी को इंक्रीज करना है तो एफएसएच डिक्रीज हो जाएगा. ओके, सो दिस एंटायर पैराग्राफ इज वेरी इंपॉर्टेंट. सो नेक्स्ट चीज इसमें क्या दिया हुआ है, convert testosterone and androstenedione to estrogens via aromatase. Sertoli cells are temperature sensitive. Line seminiferous tubules support sperm synthesis. ये सब तो देखा. Homolog of female granulosa cells. Increase in temperature seen in varicocele and Kiptort children. तो ये इतना important नहीं है. यहाँ पे एक this line is important. This line is important. Aromatase is responsible for converting testosterone and androgen into estrogen. Okay, and यहाँ पे each and every line is important. Okay, each and every line has one question in UL. Coming to Leydig cells. Leydig cells क्या करता है आओ देखते हैं. Leydig cells secrete testosterone in presence of LH. Testosterone production unaffected by temperature. Okay, so homolog of female theca internal cell. So homolog they can ask. Okay, so that's it. You have to remember nothing else. This question, one of them was there in NBME. I think retired NBME. Okay, so एक बार देख लेना, not necessary, but this function you have to remember for sure. Okay, that's it. So I will end today here. This physiology part we'll be doing tomorrow, and patho. This is a very big system. Almost we have to discuss about 30 pages tomorrow. So kal I will finish reproductive, entire physio and patho both. So if you have any doubts regarding the CVS or embryo and NR that we have studied till now, you can stay back or else you can leave. Sharing कोई doubt है?
नहीं अभी तो नहीं, and I didn't see the CVS video first वाला yet. I'll see and then if I have any doubts I'll ping you.
All right. और मैंने जिसमें बोला है प्रिंट आउट निकाल के करना है, निकाल लेना प्रिंट आउट. ऐसे याद नहीं रहने वाला है. ओके, फ्रॉम माय
Okay.
एक्सपीरियंस आई एम सेइंग यू, प्रिंट आउट निकालो, दीवार पे चिपकाओ, डेली देखोगे, वो देख के यूवर्ल्ड में सॉल्व करोगे तो आपको याद आएगा, हाँ मैंने ये देखा था, ये मेरे प्रिंट आउट में है. ओके, सो डू समथिंग लाइक दिस बिकॉज सम थिंग्स आर जस्ट टू मॉक अप. तो उसके लिए आपको कोई कॉन्सेप्ट अप्लाई नहीं करना है, दे आर स्कोर बूस्टर्स. ऑलराइट,
Yeah.
सो दैट्स इट. क्लास इज ओवर.
Okay. Thank you.
ओके, नो वरी.